Yes, Professor Dr. Jasubanta Sethi, Sir, Director, Amity University of Health Allied Sciences, to deliver the welcome address.
Yes, very good morning to you all. With the blessings of the Almighty, Honorable Founder President Dr. Ashok K. Chauhan, Chancellor Dr. Atul Chauhan, Vice Chancellor Professor Dr. Balbinder Shukla, I take the opportunity to welcome this big gathering with the students and faculty from Maryville University, USA, who already have given a information 6 months before to come to our IHAS, Department of Physiotherapy, IHAS, Amity University, during their excursion trip. I am so happy to welcome the students of Doctor of Physiotherapy program of Maryville University, as well as one student of Doctor of Nursing program of Maryville University, who are all here, all the way from USA. Professor Pradeep Ghosh is a very senior professor who has already completed his doctorate in physiology and additional doctorate in physiotherapy after going to US. He has been here second time. Along with this, the second batch of students who are visiting Amity University, where he had come in 2018 pre-COVID, along with the 40 students of DPT and OTD, with the two professors. That time we were very overwhelmed to welcome these students of Maryville University. Since then, we have a kind of heartfelt gratitude and the connection with Professor Ghosh, and where most of times we talk about the development of this profession and these programs in his university as well as in my university, Amity. So thank you, Professor Ghosh, accepting our invitation, coming over here with your DPT and DDN students. Of course, with me, we have Professor Dr. Chandradeep Tandon is the additional Pro-VC and Dean of Biotechnology Biosciences. He is with us right now. Next, we have Dr. B.C. Das ji, already you have met in F2 Lounge. He is the Dean of Health and Allied Sciences and noted scientist retired from ICMR, Delhi. We have the person sitting at the last, Dr. Tanvir Javed. He is the Deputy Dean of Health and Allied Sciences. So the few members, 3 members are the key, along with my faculty members, to make this occasion success towards getting all necessary approvals from Honorable Vice Chancellor till yesterday night. So thank you so much for all of you. And of course, this PG and PG students of the Department of Physiotherapy, Occupational Therapy and Physiology of IHAS, they are here. They will have a chance of listening what Professor Ghosh has. Already. So thank you, Professor Chandradeep Tandon ji, Dr. B.C. Das ji, and Dr. Tanvir Javed. So for this function, having in spite of your busy schedule and giving the consent to come over here. So thank you so much.
I now request Professor Dr. Tanveer Naved, Dean, Deputy Dean, Health and Allied Sciences, to please address us all.
A very good morning to one and all. I take great privilege to firstly welcome a very distinguished visitor from Maryville University led by Dr. Ghosh. A very warm welcome, Dr. Ghosh and the team. MIT is renowned for its international tie-up, and today I see a very remarkable day, especially for our physiotherapy department, for coming forward to invite a very distinguished delegates from Maryville. And once I go through the today's program, I see a very topic needs a lot of research and tie-ups, especially in the area of pain management using the bipolar magnets, and also the topic which will be covered by Dr. Ghosh, the gait, especially in the individual with the stroke. So we all know that it's a very dreadful disorder across the globe, and the gait is probably the first thing which designate the improvement and neuro rehabilitation. So I personally look forward for the talk by Dr. Ghosh, and I request my colleague Dr. Sethi that this meeting not only the focus today's discussion, but I heard that in future also the faculty exchange and the student exchange among the two university of repute can be considered. With this, I wish you all the very best. Thank you.
I now request Professor Dr. B.C. Dasar, Dean, Health and Allied Sciences, for his address.
Well, very good morning, one and all. First of all, I welcome our honorable guest today, Professor Pradeep Ghosh, along with his team of students, the postgraduate or I say, as I am told, the MD, doctoral or MD students of from the Maryville University, the physiotherapy department, along with one nursing student, and welcome you to the MIT University. And you know what for we have come. But before that, I welcome Professor Dr. Chandradeep Tandon, is the additional Pro Vice Chancellor and Dean of the Faculty of Bioscience and Biotechnology. I also welcome my the Deputy Dean, Dr. Tanveer Naved, and of course the Head of Physiotherapy, Dr. Jaswanta Sethi, and along with our own students from the physiotherapy, all are physiotherapy, occupational therapy, and physiology. So these are the three departments which called as a. So these are which are concerned with this today's topic or discussion or a scientific aspects. So I know it is mainly because of the physiotherapy topics, but there are other topics also. I understand that two topics to be discussed today, that the gait management and the pain management with the bipolar and the quadripolar magnet, as well as we have the gait training for the individuals with stroke. So, but it is all physiological aspects or physiotherapeutic aspects which will be dealt today. But along with that, those who are come from abroad and Dr. Ghosh, including Dr. Ghosh, but to tell you little bit of the university, Amity University. As you have come today, I think the students have come for the first time from US. So there are seven or eight students. Oh, you are seven students. So welcome to Amity University once again. And this university is a huge university. This campus is having around 40,000 students and around 1,500 faculty, and then the other administrative staff. It is almost half a lakh, means what, 5 million people. Half a million people. Or what is it? No. Half a million? Yes. Yeah. People comes here every day and leave. So, but this is a original and in the old university which was created it is almost now 2 decades old, and it is a just cover over the teenage. It's 20 now, I think 20 years old, and it was started in 2005. But this is the original and the main university, and there are 12 more universities in the country. So there are independent universities, and they are having the own vice chancellor and their strength of the students. So there are several thousand students. So all get together, it is more than 2 lakh students in this in the Amity University, and these universities are situated in the different campuses, different states of the university. It is like United States. It is you can say it is a republic, united country, because there are, I think, 29 states in the country, and that makes the whole India. It's a huge country, and this Amity is this is our mainly the founder of this university is Dr. Ashok K. Chauhan. He is a great philosopher and philanthropist and a visionary person. He is a scientist himself. So he was a chemical engineer, and he spent 28 years abroad and came back, and during his sojourn in Germany, East Germany, he had more than 6,000 Germans in his role. It's a AKC group of company there, and it was one of the biggest company in the Europe, whole of Europe. And he came back after 20 years of spending there to concentrate on the contribution to the nation, to building the education through educations. So that is what his journey. So he has the vision to establish one university in each state. So there would be 28, 29 states. So there so many universities will be there. So it is now 13 universities now. So it is going very fast and it is developing. So we have in Chandigarh, you have heard the name Chandigarh, the Mohali, where we have new university has come up, then Calcutta, Mumbai, and then Rajasthan, that's Jaipur. And so like that, different states, we have several, each university in each state. And there are more than 2 lakhs, 2 lakhs, this means 10, 20 millions of alumni throughout the world. They are distributed, the Amity students. So this is the strength of this university, and it has a more than 17 campuses abroad, including in US. There are 2-3 centers, including in US, the biggest campus. It is in Long Island. that is a New York, Long Island. So this is coming up as a global research hub. So also there are many things has already started. The Indian system of medicine, Ayurveda biology, bioinformatics, and other other courses have started. So it will come up as it is shaping as a global research hub. And there are also 28 schools. So if you enter into this university, 28, it's called Amity International Schools. They are top schools. They are in competition. They are coming top, one of the top schools, schools in the country. So this, if you enter into the university in the KG, kindergarten, you will come out at PhD or postdocs. So that's the way it is planned. So from the kindergarten school to PhD and postdocs, you can complete here. So this is the aim of this university, and this foundation and the founder of this university has planned this way. So this is the strength of the university, and there are more than I think 400 around programs run. Programs means courses. Including the engineering and bioscience, biotechnology, health sciences, humanities, law, and mass communications, and all this. There is no department or the discipline which is left except the full-fledged medical school, which are under construction or it is in the process. There are 3 schools to come up, one in Dubai, one in here, and one in the Gurgaon. There is also Amity University, Gurgaon, Haryana. So there it is coming up as a the medical schools and hospitals. So, but we have the allied health and allied sciences. So we have a allied science or allied health sciences groups are here, and there where it has the pharmacy. The biggest school is the pharmacy in this health sciences. Then we have the health and allied sciences, that pharmacy, then physiology, and the school of physiology, then school of occupational therapy, and physiology, school of medical physiology, and then we call it an institute of health and allied sciences. So we have institute of the neurosciences and neuropsychology. We have the public health, the hospital administration and public health, and so these are the few health and allied sciences, but we do not have the full-fledged, as I told, it is coming up. So we have also the PhD programs in all the branches. We have all the branches PhD program. We have also, importantly, we have the Amity Institute of Indian System of Medicine, which comes under Health and Allied Sciences, that is having the yoga school of yoga, and then we have the Ayurveda and homeopathy. So these are Indian system of medicines. So we have mainly now running the PhD and courses, MSc, BSc honors, MSc, and PhD in the health and the yoga sciences. So, and also PhD program in that. So these are a few of the programs. So in general science and technology and all subject, there are PhD programs. And there are the Amity University is also known as the research and innovation driven university. It is true to the words that it is mainly more emphasis is been given. The teaching learning is there in its place. It is a priority certainly, but Other than that, research and innovation is the more important here. So this university is having now H index. Those who know, H index is more than 150. It is, I think, 154 or 155 at this moment. But 160, it's cost 160. So it is every day increasing, which that's why I guessed it. So he has corrected me. So every day, today we are telling 160, tomorrow it might be 64, 65. So it is 165 or 65, 64. So it is increasing every day because publication is every day pouring in. So accordingly, and we have all top journal publications starting from the so it is almost even to the top publications like Nature, Genetics, Science, and Nature Communication, Nature. So then Lancet. So there are huge number of top journal publications, including the regular all international journal publications. So you can imagine if it is a 160, any Nobel laureate, when he gets the Nobel Prize, his H index is around 100 or up, 100 up, 120 or 130. So, but there must be some exceptional. So they may be less H index, but having impactful papers like Nature, Science, or New England Journal of Medicine. So that's the beauty. So the MIT has the over 160 H index. That means it deserves to be a Nobel Prize as a whole, not as a individual. So that's the research importance here. So with these few words, I would I once again welcome you, but nevertheless, we look forward that what collaboration we can build up on this field of the physiotherapy. That mainly there's in physiotherapy, you see, it is important. It's a important area of discipline or the medical discipline, which every person from childhood to young old age, everybody is affected every time. And though there are medical school, there are the famous doctors and the expert clinicians give the treatments and all from surgery to whatnot. There are all methods and the particularly orthopedics which are related to you, orthopedics or other deformities that this discipline or this professional gives the immense happiness or the useful for the people, for the childhood children to old age people, because even if you have a successful operations and all, so you know how it is important that you need a physiotherapy or physiotherapist to do, or physiotherapy professional to do that, to do the physiotherapy practice and give them the physiotherapy so that they are able to walk, or they are able to move their hands, or maybe they are because of spondylitis or spondylitis or anything, or any the leg fracture or anything, any operations or any orthopedic surgeon can do, but you only can be able to walk with the help of physiotherapist. So you give immense happiness and the help from the childhood to the old age people. Those who are invariably they fall down or generally in the bathroom or elsewhere in the at home mostly, and they are at that time after operations only the physiotherapist, or even they may not go for operation. The physiotherapy alone can cure them. So this is the profession. So you have to say noble professions. So, but then main important of that is anything you met with an accident or you fell down or whatever you face, that creates the immense pain. So major importance is the pain relief. Besides, your surgery can correct things, but to make things working and to remove the pain is the job of the physiotherapist, because it is not only the painkiller. If you take painkiller maybe 10 days or 10 months, you can go ahead with that. But whole life you cannot get the painkiller, because that will cripple your other systems, or your KFT or KFT, LFT, and all aspects will be affected. So the liver, kidney, and all aspects will be affected if you continue to the painkiller. So the physiotherapy is very important, and to relieve the pain. So that is what the main aim of this workshop and the collaborations with the US partner, Professor Pradeep Ghosh, and it is, I thank profusely for his interest to come up. So see, he is from India, so we expect the Indians to come, and what they have the excellence in their field, achieve excellence abroad, and they come back and contribute to the nation building some way or the other. That way I appreciate and congratulate you that you have taken that initiative to come over to India, to this Maryville University, and to train us, and whatever possible to extend the skill, the transfer the skills and other training, so that our department can come up with this technology, the pain relief, that is a magnetic magnet used for the pain relief. So the way the bipolar or quadrupolar polar way, so whatever is the possible. So new skill for the pain relief, it will be we welcome this, and we hope our department will be successful in gaining this technology. And I can mention other day there is a team from USSR, the Russia. We had the team, Elamed. So you must be knowing. So they are also with the pain relief system. What is that, Elamed? Electromagnetic, pulse electromagnetic therapy. So they also, I had some back problem. They also suggested that they will try on me. So they have already given some machine. So, but that has to be regularized, and MOU to be yet to be signed. And I think we will also signing MOU with Professor Ghosh. So, right? So that will initiate the formal initiation of the project or the collaborations. So at the same time, I also tell what I was telling in the just few minutes before in the lounge, that you have come first time to India, try to see what best possible. How long you will be staying? Another week? So just see how much you can see with this short visit, but later on you can come for spending your summer days here. So because I know I have spent several years in Germany and UK, and these a lot of people came, lot of my friends, their colleagues, they came to visit India and stayed with us also. And so you can take that initiative, and you can come to Amity also and stay here. So we have a nice guest house. So that's that invitation, standing invitation. So you can see India. There are huge things to see. So it's a really country to see. So there are huge number of things. I don't want to extend. So you can go through the literature, and you will find everything in the net. So in the Android phone, so you can not to go for searching for any literature, but you can see in your phone itself. So once again, I thank you all and welcome all for this nice workshop, for the scientific workshop, and we'll see what we can learn, and we can collaborate, and it should go in a better way. And we congratulate the Department of Physiotherapy or Institute of Physiotherapy or the Health Allied Sciences, so, and their colleagues and all the faculty colleagues. Thank you very much for your cooperation, and thanks very much. Thank you.
Thank you, sir. I would now request Professor Dr. Chandradeep Tandon, sir, Additional Pro Vice Chancellor and Dean Faculty of Biosciences and Biotechnology, Amity University, for his address.
Very good morning to all. Yeah, this works. On the behalf of our Honorable Founder President, sir, our Chancellor, sir, respected VC Madam, Dr. Das, I welcome I can see Dr. Srivastav being there. Dr. Srivastav you can see him. Good morning, Dr. Srivastav. Dr. Srivastav is, he couldn't be here because he fractured his fibula. So
Very good morning, sir. Very good morning to all of you.
Good morning, good morning. Morning. So you can very well, see the importance of physiotherapy. Once his fracture is healed, he will definitely be going for physiotherapy. I'm sure. So
Yes,
this
sir.
is the importance of physiotherapy. So to start with, so I welcome Dr. Pradeep Ghosh and all the students. I can see them. Is it your first visit to India, all of you? Yeah. When did you reach? When did you reach India? 2 weeks ago. Okay, that's really great. So believe me, Dr. Jaswanta, under the mentorship of Dr. Das and me together, we have been working on designing this program for all of you. Am I right, Dr. Jaswanta? After lots of efforts made by him and Dr. Das and everyone together, and after our Vice Chancellor also. So we have come up with this program, and I am delighted to see so many students here wearing white coats. Though in this particular hall, seminar hall, there are students and faculty only from the three institutes, namely physiotherapy, physiology, and occupational therapy. Is that right? But the influence of this particular seminar here is going to be all pervasive, because each and every individual, especially in the old age or any age, God forbid, if they have some other, and any other disease, physiotherapy is something which everyone needs. So whether they are present here or not, but the outcome of this particular interaction is going to be immense. Am I right, Dr. Das? So everyone needs it. Dr. Pradeep Ghosh, you very well know. Now we are looking forward to your lecture soon. And the program here, the very important part, I see a research meeting on pain management using bipolar and quadripolar magnet. This is a research meeting. So where I guess all the students from Maryville, Dr. Pradeep Ghosh, and our own students, they'll be interacting. And this is going to be very, very important for this meeting. So this meeting is today at 11:10 to 11:40. 30 minutes have been given to it. So we expect very good interactions and outcome out of it. So I won't speak too much on it, because now we are waiting for Dr. Pradeep Ghosh to enlighten us with his research findings, and the outcome of this particular interaction is going to be the research collaboration. Am I right, Dr. Jasubanta? Yeah, research collaboration. So research collaboration. MIT University, Dr. Das already has said, is a research innovation driven university. We believe in research, we believe in innovation, which is evidenced by Dr. Das just said, the H index of the university, which has gone beyond 165 now and is likely to soar further high, God willing. So with this, I once again welcome you all and good morning. Thank you so much.
Moving on, now we have a presentation by Professor Dr. Pradeep Ghosh, Professor, Maryville University, USA, on the topic Gait Training in Individuals with Stroke.
Good morning to everyone. This is my second time here. So thank you, Dr. Jason Sethi, to invite us, and Dr. Das. I met them before, and we are so happy to get this hospitality and giving us a chance to interact our department with your department. I think our students are going to get something out of it. And when they interact with the students and they can learn about how the students here they learn from their professors. So I know that we have a limited time. Generally, this talk is a whole rehabilitation talk is for 2 days. So I had to limit to some about 30 minutes or 40 minutes. I'm going to limit it, and including my research, which I am going to talk about, the collaboration that I have started with using the magnet in pain management. So let me talk about the stroke, right? Some of you are physiotherapy students, some of you physiology students. I know them, so I'm sorry for the students who are physiology. I'll try to connect something about the physiology with the physical therapy through this lecture. So one important part after stroke. Stroke is just the accident, the neurovascular accident in the brain, and caused by multiple different reasons. Different factors contribute leading to the stroke. And stroke can lead to irreversible damage to the brain. So the stroke, if the patient has a stroke, they will have some residual problem. It will not be reversible. So the different impairments, functional limitations, all of you are, some of you physiotherapy students, they know that one. A lot of different impairments patients are going to have after stroke. So one of the important part is a gait. So walking. Walking is the most important part after stroke. All the patient, they need to get back. And if they don't get back, they have a lot of secondary changes. One of the change means that they will have depression, they will have anxiety, they will have a lot of other problems, and that can cause more downfall of all these things. So abnormal gait pattern are a common impairment following the stroke. And this is again, the gait changes is a multiple different interactions when there is a change in the brain in certain areas. And we know that when the gait will be affected most of the time, this is because of the impairments or because of the limitation of blood flow through the anterior cerebral artery. Anterior cerebral artery is a branch of the internal carotid artery, and that supplies the medial part of the cerebral cortex. And it is going to affect the lower extremity, and gait will be affected. Sometimes you'll see after the stroke, patient will have the upper extremity involvement more. And when the upper extremity is involved more, some other blood vessels will be affected, their flow will be compromised, and middle cerebral artery is one of the culprit for that. So that when patients, their anterior cerebral artery, their blood flow compromised, they will have the impairment in the lower extremity, and gait will be affected. So when patient has the stroke in the medial part of the brain, and it is not going to be limited on that area. It's going to affect the other part of the brain, including the brainstem. Midbrain has important part, and that play a role in the rhythmic movement. So that will be affected. And also not only the midbrain, other part of the brainstem will be affected, causing more problem the patient is going to have. So what are the limitations patient is going to have? I'm talking about the limitations only based on the lower extremity function. So they will have the muscle tone will be affected. Muscle tone, all of you know that muscle tone is influenced by the brain, by all the descending motor tracts. So their muscle tone will be reduced or they increased. Immediately after the stroke, patient will have a muscle tone decreased. They will have a flaccid, and after that they will have the spastic changes. So flaccidity or the spasticity is going to limit their movement. It is going to limit their movement. Gait will be affected. Their muscle strength will be affected because of all these tracts coming from the brain. They are going to influence the alpha motor neuron, gamma motor neuron. Their output will be influenced. And also another important part, not only that, their timing, the timing of the gait cycle will be affected because of the involvement of the brainstem. So timing will be affected, right? And they will have, because some patients, they will have the one-sided involvement, and they are going to develop a lot of adaptive changes. So causing all asymmetric gait pattern. And not only that, when the patient has the stroke, they will have a balance problem, they will have the sensation problem. All these are important factors for maintaining our normal gait. So in order to have the successful walking, so support of the body mass by the lower limb, that is very important. Patient might have the weakness in the lower extremity. The knee can be collapsed, right? Their knee strength, the muscle strength is low. They do not generate adequate force during walking. As a result, that is going to affect there. Because when there is a change in the brain, and there will be a lot of consequences. So muscle strength will be affected, and that is going to limit their gait also. Another part, you are going to see that one, locomotor rhythm. That will be changed. Patient one side is affected because of the stroke, and other side is normal. The normal and the other side, the one side is normal, another side is affected, they will have an abnormal pattern. Their rhythm will be changed, locomotor rhythm will be changed. And in order to do that, they will have a lot of compensatory changes. That's why I'm talking about this one. These compensatory changes, when they will have, because the brain is going to be changed based on the environment, based on their function. That when they have some adaptive changes, and brain is going to take that one as a normal. And as a result, one side is normal and other side is abnormal, and patient is going to have the asymmetric and causing more problem. And one consequence is a fall. Right? All the patients, about 90% patients, if their lower extremities are involved with the stroke, they'll have a fall. Right? So the important part, very important part, during acute phase of rehabilitation, very important, first few months. And that is the time the patient's brain is going to be modulated by external influence. We all know, patient has a stroke, cannot do anything. That is not true. So you have to force the patient to do more during that time. And that is the time the patients will have more changes in the brain. So we have to promote symmetry. Patient is sitting, patient has a stroke, and patient is sitting, leaning to the unaffected side. And that means asymmetry. We are promoting asymmetry. Is that right? No. We have to promote symmetry. How are you going to promote symmetry when the patient is sitting? It's always better to put the patient in the bilateral support, arm support. The patient is sitting on the chair, and some in the front, patient might have some table and keeping the both arm. If the patient both arm is on the table, and patient will have a more symmetric sitting. So that is one example I'm giving. So promoting symmetry from the start is going to have a huge impact in the outcome. So symmetric part. Another part, we know these are all pre-gait. We know we have to focus how the patient is functioning when the patient is getting up. When the patient is getting up using the both side, right? Patients will have a tendency, patient is going to overuse the unaffected side and leading to that side and stand up. In order not to promote that one, sometimes you guide the patient arm. If the patient is going to push and using the arm rest, and patient is going to use the arm rest unaffected side most than the affected side. So in order to reduce that one, you just guide the patient. You just guide the patient, keeping the patient both arm in this place, and you guide the patient. You guide the patient to flex forward, lean forward, and keeping the arm up. And when the patient is the arm in the symmetrical, they are going to use the affected side also during sit to stand, right? So another way. And part of this, another problem, when the patient stands up, patient is going to lean to the unaffected side. So keeping the patient leg to the affected side And patient will have a fear. Oh, my this side leg is weak. I'm going to fall. So you guard the patient on that side, stabilize that knee, stabilize the ankle, right? And when the patient is good enough. And practice should be repeated. We know I saw that one several places in India, in America, some places, United States, in some nursing home. Just stand up and sit down 1 or 2 times. It does not work. It does not work. We are focusing that function, we are promoting that function in order to change the brain, in order to have some effects on the brain. Then patient is going to learn, patient will have some carryover. So it is very important, that part too. So weight bearing on the involved side, right? If what can be done? If the patient starts to lean to this side in the chair and stand up, what you can do? You just limit this side. How we are going to limit? You just put a small block or phone book underneath the feet. So you raise that one, patient knee will be flexed, hip will be flexed. When the patient is going to lean forward, patient will be forced to use this side, the affected side. Right? We can do that part. It is not that simple. It is not that easy, but you can do it. So another part you can do that one, just position of the foot. If the patient is sitting on the chair, patient, let me go down because I don't have the feet that I can. Because I like to demonstrate. I like to demonstrate everything so that everybody, all the students, they know that is what I'm talking about. So when we are going to talk about that, when the patient is going to stand up, patient is going to be like this, right? And when the patient is going to get up, patient is going to get up like this. So I'm going to limit the patient to make more symmetric. Right? I'm going to put something. I'm going to put this. These flat, when patient is going to lean forward, patient will be forced to use this side. Here, very simple. You don't have to use any sophisticated device, right? So my goal is to come up with some technique so that that doesn't cost that much money, right? And patient can learn and patient can practice at home. So that this can be promoting the symmetry early on, very important, right? So that patient will be more symmetric and will lead to less incidence of fall. Sometimes the patient, when we do, patient has a fear. Oh, I'm tired, I'm getting tired. So patient has to have a standing tolerance. So patient is going to stand, and one standing part patient you can promote that one in the plantigrade position. You know what is plantigrade position? In the plantigrade position, patient standing, when the patient is standing in front of the table, right? Patient is standing like this. This is the plantigrade, right? If you can lower, the patient will have a more weight bearing on the upper extremity. You can raise that one. You can control it. The patient will have a more weight bearing on the lower extremity. Now the patient is accelerating. And if this side is affected, and with the patient, we are going to put the patient, and if the patient foot under the foot, we can put some phone book or the block, and the patient is pretty strong. And patient, as soon as you raise this one, patient so very simple, right? You should have a view of that. A lot of people say, what is the research behind this? When in practice, how many clinicians they report that what they found after treating the patient? Not that many, right? So I have the experience. When I see a patient, and my most patients, they are all either stroke, the Parkinson's disease, multiple sclerosis, or neurology. Can I treat patient with any orthopedic? Yes, I do. Can I treat any patient with the pain? I do. But my main thing is neurology. So the standing tolerance patient has to have. This is the one plantigrade position. See that simple standing. Which side is affected on this? On the patient who is on the stool or the step? Which side do you think is affected? Left or the right? Left side, right? Because it's the patient is forced to use that side more. So now, another part, during walking, patient will have some changes. When the patient decides that the patient have the wrong pattern, patient the pelvis will be muscularly rotated, then it will make more patient emphasize and patient will have longer adaptive changes. So what you can do, the patient is a planning position or standing, the patient can simply the march and encourage the patient pelvis. And when the patient fails, the patient is going to march. Here we see the patient will have. See that is very correct. Right? Invitation. Right? And followed by function. So just connecting and I'm done with the patient. That part I connected. No. The patient has to use that word. The patient is going to go over the patient and the patient is going to walk. We see the patient is still there. We connect it. Right? Very important early on, right? Those things I'm talking about, not the true gate, but pre-gate training. Right? Pre-gate training. So again, balance is another part, right? The standing balance. Standing balance important. A lot of patients, they will have a fear. Their balance will be compromised. Multiple different factors can contribute, right? And patient, one thing is a patient might think, oh, I'm so weak, my knee can be collapsed, right? So you can sometimes during this functional training, you can use some sensory stimulation, sensory. So one part I know when I was in China, I went to China for a meeting, and I went to, whenever I go to a different country, I go to rehab setting. And I saw they were using the ear splint, whole body. If this side is affected, their arm is covered with the ear splint. You know, ear splint is the sensory, you can give the pressure and sensory stimulation. And when you bend the elbow continuously, that pressure will be changed, right, on the ear splint, and patient is going to have the sensory information. Same thing in the lower extremity. They use the pressure splint. Ear splint can also be used to stabilize the knee so that the knee will not be collapsed during standing. So you can put the ear splint. Sometimes the patient gets, the patient is so nervous, so I cannot stand, I cannot walk. Sometimes you can give additional support using the harness, right? Standing trim can also be used. So in order to improve the balance, that is the criteria patient has to fulfill. Otherwise, patient will have a fear, patient will have a limitation, patient will have hesitation. And if the patient does not enjoy the functional activity, most patients, they don't. But the way we do implement the therapy, keep the patient more happy, at the same time, you are challenging the patient, right? Sometimes you say, oh, the patient can stand up, and patient is looking up and down. It's very simple. Looking up and down, looking up and down. What patient is going to do? When patient is going to look up, patient, one side is affected, patient will have a difficulty, hesitation. I'm going to, my knee is going to be collapsed. So you just promote that one, looking up and down, looking sides, right? And looking behind. And another part during movement, the feedback is very important. Feedback is important. And one type of treatment I use it is using the laser light. So laser light guided movement. We have a paper published, that one. So we did it at Maryville University. Not in the patient with the stroke, but patient with the Parkinson's disease. So if you put the patient, patient cannot look at this, patient upper extremity, shoulder, there are a lot of, the has a problem. You put the patient laser light here and ask the patient is standing in front of the wall, and ask the patient, okay, look up. Here's a line. You put the line here. And there is you plug that line, someday, and patient is going to do like this. Or you can put the target. The target is there. Patient has to do that. And some patient is going to do that one. Patient may look like this, right? This is not okay. You have to control the patient. Trunk will be extended like this. Patient will do, right? So laser light will be good. For example, same thing. The trunk rotation is another important factor that is going to help the patient is proper thing. If the patient cannot rotate the trunk, how the patient is going to shift the weight from one side to the other side? So during trunk rotation, you're also going to put the laser light and ask the patient to stand sometimes and put the patient on the rigid line on the wall and ask the patient patient is the line 1, it's the line 2, the line 3, patient will do that. So this is the rotation of tongue. So patient gets the feedback. So laser line guided movement is very important. And to help the patient, right? To help the patient, to motivate the patient, to engage the patient. Patient has to be engaged. So some patient, oh, patient doesn't care. They are doing something and patient doesn't. Will that be done? Patient not. So those are important part before get training. So weight shifting exercise, anterior-posterior weight shifting, sidestepping, those things, and reaching action also, that is going to improve the patient's standing balance. So another part, important part, and in order to have the proper page, right, during active stage and sub-active stage, we can promote some bridging activities. Bridging activities are the extension and inflection. This is shared. When the patient has a gait, here you see there insufficient inflection. And that might be because of some problem in the membrane. Might be some kind of the hypertonic concept. If the patient has the body stress, they have a capacity, patient has a ability to manipulate. If the patient has body limited, then promoting this with the hand may not work. But if there is some technology and use it, some simple technique when we use in order to reduce that one before we get there. Right? Will that have any carryover? Over time, if you do IS, say that over time, it has some effects in reducing the load. Load reduction is a big challenge. And the patient has hypertonic muscles, there's a big thing. We have to have some kind of strategy to reduce it. So bridging activity of functional activity that has done the risk. Right? And also another part that we have to increase the strength of the at the times, acute and subacute phase. There will be some diffuse atrophy, there will be some effects from the stroke, there will be several other things because of the depression, no movement, lack of movement, all is going to. So you have to do some other activity, say for example, supine knee flexion and the hip extension over the edge of the bed. Another part, we know that, we also use that one, is a PNF pattern, right? Certain pattern is going to promote the way, the movement we use during the walking. The important part is the reciprocal action. How quickly we can do the reciprocal action. Gait is the reciprocal function. How quickly? What are the different strategies you can do it? One is that reciprocal, it's a march, it's a reciprocal. When the patient is sitting, patient is not doing everything, our patient is sitting, and you ask the patient to march. And what patient is going to do? Decide the effect the patient will do. Then this is going to happen. This effect. So how are you going to promote more symmetry? So one we can do again, or you can do metronomics and other thing we can use it. I use those things. Feedback is very important. I'm not going to use the feedback using the virtual reality. Those are expensive. I'm going to use a simple. I buy one metronome and ask the patient, okay, you just follow the sound. Right? Patient has to one thing I have to put it, not that patient. But when you interact with the patient and give the importance, it's a patient education, and then give the importance, and patient can feel it, and patient can see it, and that one. How are you going to do that one? You can put the metronome and ask the patient, what is the sound of the metronome? And you are going to also do that at the same time. Patient is seeing you, patient is listening that one, right? The sound. Right? Marching is a good one, and then followed by the fight. While is a patient is doing the light, the bilateral, right? Those are so those things I do before. I always say that chronic, when the patient is chronic, it's after 6 months. It's possibly once the acute 3 to 6 months, after 6 months. Still, the patient has a chance to get back some function. If the patient 2 years, 3 years, 4 years after stroke, so already rehabilitation, very good. So promoting symmetry, right? Very important. Reciprocal action for. So now this is the weight bearing, right? On the side stepping, right? Stepping up, right? Sometimes you see the patient is going to, patient has already one year post-stroke, and patient is walking like this. The patient is walking, this side is affected, patient is walking like this. Either walker or pain patient is using, is taking a step. The patient walking, this side is the pelvis rotated. Sometimes I also do something like gate valve. If the patient has a gate valve and put the weight on this side, several action. This is going to force the patient to use this side. It is going to give some kind of cue, put this in the cue on the pelvis, when the patient is going to walk. Patient is going to walk like this, you have to cue. The patient is going to take a longer step. So weight on gate valve, that is our research also. We publish that one, but it's a distance. It's not the full best. It's so difficult to get the patient there too because our university is not attached to a hospital. So another part I'm going to talk about, the stretching. So how much time I have? Yeah. So the another part, the stretching, right? Stretching is a lot of patients, they will have some contraction. Stretching needs to be done also. That's substitute stretching, stretching the calf muscle, stretching the soleus muscle in sitting, right? Passive stretching of the rectus femoris. Stretching is another part because it is going to have impact to reduce the secondary impairments, means the contraction. If you do not stretch the patient muscle and you build some strength, strength is going to have certain kind of function, but at the same time, you have to do some kind of stretching in order to increase the extensibility of the tissue. So the hip extension is supine by keeping the affected leg over the side of the bed, right? Side of the bed, and that is the hip extension pushing. So strengthening activity needs to be also incorporated. So I'm talking about all the impairments in order to promote the gait early on is very important, right? Strengthening. Sometimes, when you strengthen, you can use some kind of electrical stimulation, functional electrical stimulation. When the patient is walking, you use electrical stimulation to promote the function. So all the motor unit recruitment that is used for building the strength or getting the strength back. You can do that one. Functional electrical stimulation is also important for rehabilitated patient in order to promote normal function. So the electrical stimulation, EMG biofeedback is also weight bearing through the limbs and the practice of walking through promote. Think about that one. This is the one from the one paper. Look at after the stroke is the cross-sectional mid-thigh area. After the stroke, 20% lower in the hemiplegic thigh, right? So muscle atrophy of the muscle, motor unit recruitment pattern, right? And contraction of the soft tissue, all are going to have impact in compromising their gait and promoting asymmetric gait. So gait training is a motivational. If the patient is sitting on the chair, got the patient up from the bed, putting the patient in the chair, without any walking or gait training, patient gets more depressed. When the patient knows, I still can take a step, and that is a lot of motivation for the patient. Patient participation is very important, and participation depends on multiple factors. One is the motivation. If the patient motivated, I'm going to do that, and patient is going to. And patient feels, I took yesterday 2 steps. Let's try for the 3 steps today. So it will be motivational. So always not keeping the patient in the chair, right? Even the patient is the acute stage. We have to give some kind of with a lot of help, give some steps. There are several things. The patient can be in the parallel bar. Patient can get help from the 2 therapists, right? So it can be. During over the ground gait training, it is important to break down the whole task into component, right? We talk about the symmetrical weight bearing between the 2 lower extremities, weight shifting between the lower limb, stepping training, heel strike. Those are the component. We can promote those things. And then we can integrate everything together in the functional context, right? We can integrate. That's the conventional type of, right? So we know what another part I do talk about that. So when the patient, we start the patient to walk, differently with the parallel walk. If this side is affected, if this side is affected, always we are going to ask the patient to take the step forward to the left side. When the patient is getting there, patient will have time. The patient can control this side, the patient will have not have a fall, and patient will have some time to take on this side. Taking forward, right? On the 100% cost. What's the other benefit? If the patient, if the patient can take a step using the affected side, the patient can take a small step, and this unaffected is going to fall. If you're sort of velocity. If you ask the patient to take this one, and the patient has a feedback from the outside. Patient has a intention to take a little bit bigger step. The very small is important. Those are very simple to think about and can implement, and it is going to have impact. Here, within the parallel bar, same thing. Yes, spleen around the knee, we talk about that one. Parallel bar, ambulation, treadmill with the harness is another one. Treadmill is a good exercise, more symmetric, right? It is going to promote more symmetric. Treadmill patient is going to, depending on the speed, patient, we can implement that part, right? We are going to see the patient, the trunk control will be another big part, right? And patient will have the alignment problem, upper trunk and the lower trunk alignment. If the lower part of the body is affected, the alignment, and that is going to have some impact in the walking characteristics. So one part, loss of control of the upper trunk over the lower trunk. If the patient, when they walk in the forward progression, upper trunk must remain balanced over the lower trunk. Pelvis should be that perpendicular. And when the patient with the hemiplegia, they are going to talk, they are going to walk, and you are going to see the patient, this trunk alignment is going to be disrupted. And that can lead to some adaptive, some compensatory movement. So those things we can correct. And one part I'm going to talk about that one. This is the part I'm going to do. The stance phase control, such as the initial weight acceptance, mid stance control, forward weight advancement during the stance, and that will be affected, that will be changed. So foot drop is another one. Those things can be very, very effectively can be controlled. I forgot some of the things I always carry. My laser, that light, gate belt, elastic band, but I forgot this time. This is the one I got. That one we have we published this one, and very simple. I do not know how to simulate that one. How to make that one. So when the patient is going to walk, patient is walking like this. Simple. Just like a pillar band or elastic band can be put. And you can wrap around the foot and cross it. And then you have you have to have a dog. So I'm going to take out my belt. I'm going to put my belt on. So this is a very simple thing. If you want to see that one, she can feel, or if you want to feel that, I'm going to do that one. If it's longer, I can put it here. Now she can walk and you feel it. So it is going to have some impact. It fixing the loss of relation and the income. And the patient has an obstruction and the patient right? Very simple. Very simple. If the patient has a foot drop, only foot drop. If the patient has a foot drop, what I'm going to do that? I don't put the inflection. Try only control the patient foot, right? So I'm going to put here. That's promoted occupation and building. So patient might plantar flexion, right? Plantar flexion, maybe patient goes flexion. Because they don't weakness the plantar. Or maybe patient might have weakness the daughter. Or patient might have some stone the plantar. Or patient doesn't have sufficient inflection. And patient, because the patient doesn't have sufficient, we can promote the loss of function and it is going to promote more. So we can use the elastic band. We are going to the patient and control the movement, just the ability, or using the hand, or using guiding the patient movement. I'm going to walk the patient and do some elastic band. The patient can walk. So we publish one paper. Right? The other one. The patient, those are patients there. Some patient after 3 years of stroke, some patient after 2 years of stroke, some patient thank you is after 2 years. So you have shown that this technique will have improvement. Patients say we are more secure. And I saw when the patient walked, we is therapy or relaxation. Patient is walking, probably more this. Patient feels patient get into endurance. So using this one, right? The promoting reflection, promoting dorsiflexion, right? Whenever they say that, use an elastic band. So very simple, right? For example, another one I had to go there. This is the one I also use. Some patients, they have upper trunk involvement, lower trunk involvement, they have insufficiency, they have the posture, they have a lot of research, they have said that postural correction will not have any impact in our outcome pain. But I have to say that, and there are some research on that postural correction has some impact now. So what I do generally is I also use a patient who has some stoop posture. Stoop posture. I can use the gait path, I can use the therapy. Right? What I do generally. So we have the gait path. Oh yeah, yes. You know, whenever I go, wherever I teach, I do have stretching. Let everybody can see it. The way to do it. This one here. What I do generally, I also use here. I also use the weight. I can put the weight here. You see, the patient walking, deformate, right? Patient has something done to us experience. Here, patient is here walking like this, and patient will be walking. Very You don't have to do that. You don't have that. You don't have to say patient. Oh, just you say patient. Based on the patient, based on the patient, based on the strength of the patient. If you put the weight of the gate belt on the side, patient can collapse. So you stop it in the gas leg. So those things are very simple to implement, right? Not to buy the sophisticated instrument. Because always my goal is to get some affordable technique so that all the patients in their discharge home, they can manage support. Very, very important. When the patient is discharged, the patient is functional, patient will be down very quickly, but if the patient will not manage. Right? So that's very important. Yeah, I know I took a little bit long time, but I have to talk about the research too. This is the one putting the weight on the gate belt, walking forward, walking backward needs to be practiced, right? Backward is another part. Every time the patient walk, backward walking is going to improve the patient balance. Backward walking is going to play a role in initiation of movement. When the frontal lobe is involved, in the prefrontal cortex and the premotor cortex is involved, their initiation will be affected. So initiation will be affected. As a result, patient will have a difficulty. Some patient is discharged, you see the patient complains, so I had a fall. And in the kitchen, when the patient has a fall, when the patient tries to open the refrigerator, take a back step. When the patient is trying to open the door, back step, patient will lose the balance because their initiation will be compromised. So again, these are all NDT. That you don't have to do this. If you have some techniques using the TheraBand, using the elastic band, you can use those parts. Okay, so this is the backward I talk about. So this is the elastic band I just mentioned about, right? So I didn't put any kind of the evidence because I know I have a limited time. I have to finish those, right? So evidence is very important. Using evidence in the treatment, implement it because, and also contribute to the evidence because what you see during treatment, there are some website, the American Physical Therapy has, the Chartered Physiotherapy Association they have. If somebody can put that information, then everybody can get that information. Generate some evidence. And we don't have to stay with the principle that is in the book. My another goal to my student, is to think, these students also, is to think and ask yourself why I'm doing this. Can I change it? How can I change it? How can I improve it? If you can do this way, and you'll come up with some idea. All the TheraBand, I have 25 different ways to promote movement. It is in the city. In the patient that means is a laser light. I can promote any movement using the laser light. I don't have to buy the virtual reality. I can promote movement very cheap way. So think about and implement. That is the key, right? Okay, so everybody got something out of it. Okay, and any question you can ask me. Hope everybody got me and heard me. So think and come up with a new idea, right? Do not stay with the book. All right, thank you. Now I'm going to talk about the research that, can I continue?
2 minutes can ask.
Okay, yeah.
Any question?
Anybody have any question regarding the discussion? What Professor Ghosh has enlightened us with a very practical thing about the gate training. So anybody have any question? Okay, I think no questions.
No one? Is that okay?
Yeah, I have one.
Okay.
Because I was very fascinated about that CT scan, because here in sarcopenia, few of couple of studies are there, and that in clinical we have this circumference of the thigh, that is suprapatellar, this mid thigh, that infrapatellar. So there you have shown it in the CT. Have you any come across, or is there any study that pre-post this CT, sorry, MRI, is not CT, MRI, any studies are there? Is there any development of those this anterior, then lateral and posterior muscles?
Yeah. So the question is that whether there is a change after treatment, what are the different treatment is available to prevent that atrophy? So the research is shown, that means if we can, that they have shown that one, at least about 10 to 25% increase in the muscle mass through, somebody said, oh, the electrical stimulation is going to work. Somebody said the functional electrical stimulation is better. Somebody said the sensory sensation is always better. Somebody said it keep the patient inactive. Use that one. Yes, there is an evidence, because it shows at least about, there is a chance about 20 to 40%, sorry, 20 to 40% improvement in preventing that atrophy. Atrophy, that one. It can be diffuse atrophy. Yeah. That is probably added to the effect from the stroke. So when you stimulate that one, you can at least prevent the diffuse atrophy, right? So it is not going to progress that part. There is evidence that the several things mix up, functional activity, using that affected extremity is going to build some strength and reduce the diffuse atrophy. Any other? Okay, let me talk about this one. This is the, okay.
Good morning, sir. Sir, my question is regarding your research that you had just told us about. We are mainly focused on providing the initiation, and we want that the muscles of the stroke patient need to contract on their own. Trying to promote that kind of a thing in stroke patients. But when we are using the elastic band, we are neural pathway by repeating the process as well. But at what stage or in the what stage the patients were during the research? Because if the strengthening process, like you were saying, with the help of the TheraBand we are doing, then it is not exactly promoting the self contraction of the muscle, if I'm not wrong. So I'm not understanding.
So what is the reason behind that? So reason behind that, once the patient self-initiation, when the patient self-initiation is so they don't have sufficient power. They can train that. But we are adding some of the assistance to that. These assistance over time, the patient is not pain. At some point you see that one patient has some changes. So the message behind that you are sending the information to them. If the patient cannot, patient not going to lift that one. You ask the patient to lift it, patient is going to have some, oh, I cannot lift it. Patient will have some kind of the negative impact. Patient is going to avoid. Patient is going to have more compensatory. Patient is going to try to use this one. Patient is going to take a small step. But if you use that one, what is using? We know that it's an initiation. This initiation patient is getting some help. We are talking about not here. We are talking about the brain. Once the brain is going to be, there is a change, and then you are going to see the patient is going to initiate more, and patient is going to get strengthening activity. Definitely have to do it, because when the patient is getting the elastic band, will that have some impact in improving the strength? Yes, there will be. But not that much, right? Because the patient is supported with the elastic
Yes,
band,
it's supporting.
right?
Yeah.
But we are talking about here.
Okay.
Because the patient, it is good to motivate the patient. Patient participation will be good. Those are the factors. It is going to have secondary impact more, right? That's the reason.
Okay.
Yeah.
So one more thing that you talked about gate training
training,
and
yeah.
gate training.
Uh-huh.
So this part will involve in pre-gate training or in the gate training only, like
No,
or
to
both.
start this pre-gate training, you have to
Pre-gate.
start from the beginning, right?
Oh.
I started in the acute, and patient, they get benefit out of it. The normal traditional training and using some assistance with the elastic band, patient gets better. They walk longer distance.
Okay.
So you use that. Even the patient with the chronic, you can use that one. There's a chance they might get better the ambulation.
Thank you, sir.
Any other question? Okay, let me talk about the pain. Why I'm interested in the pain.
There's one more question, if you allow.
Okay.
Hello, sir. Good afternoon. Sir, I would like to ask if I want to apply rhythmic auditory cues in a Parkinson's patient. So, yes, sir. So, how it will help in forward propulsion of COG in Parkinson's patient? So, there are some studies in music therapy. So, that's why I'm asking.
So this is how this cue, the visual cue or the auditory cue is doing how the patient is checked. Because patient consciousness is in their main problem. One problem is the issue of problem. Bradykinesia, hyperkinesia, whatever you think about the issue of the problem, the connection of the brain. So there are areas in the prefrontal cortex. The prefrontal cortex, one is called the supplementary motor area, one is the prefrontal area. The basal ganglia is connected to the supplementary. Supplementary motor area is based on the internal cue. They lost that. They have to depend on the external. So when you get the external cue, either visual or auditory or music, whatever music, auditory, visually, they get that. They bypass the supplementary motor area. They get that. Is that the good way that the patient can get back on the pump? No. They have that connection somewhere, that connection is not. But that's the key works. Because it's an externally guided movement. And the patient participants in the internal guiding the movement is lost because the supplementary motor area is very connections to the stuff. Any more? All right, so I am going to talk about this research a little bit, right? So we know that I have been collaborating with different institute, different university, and I have started already because initially that when I was in Canada, I went to Canada, and there's a person from Australia came, and he was with the magnet. I know the magnet, and same time I had some wrist pain because I was carrying my luggage, the heavy luggage, and I had the wrist pain. So he said, okay, this is pain, let me try this. I put that magnet on my wrist. And following day, my all pain are gone. You might think, oh, I put the wrist, there are some sensory stimulus too, because I wrapped it. That's not true. Because once I take the magnet after 3 days off and put some wrap, still it came back, my pain. Then I started, okay, let me put the magnet for at least 7 days, 3 to 4 hours per day, not the continuous. Then I found my pain from this wrist is gone. Now I started pain on this side. So, that as we age, we have a pain. Everybody has to deal with the pain. So I came up with okay, let's try this one for others. So one of my colleague has the back pain. So I talked to the Australia, they do manufacture this pain, and I'm collaborating with them because they are providing me all the magnet. So I started the back pain, patient with the back pain. Yeah. I started using the patient, this magnet and the back pain. And back pain, I initially thought how it's going to work. The back pain is going to work, is going to be reduced. I didn't do anything. I didn't assess anything. Only the pain intensity and patient, just the subjective information. So when patient said, "Oh, I'm feeling better," so he said, "Oh, I feel better now." So then one drawback, I use the tape. And he started having some kind of reaction, skin reaction from the tape. Then I have to find how I'm going to put that one then. Then I used a Velcro, and he said the pain after, I think that 10 or 11 days, patient said, "I'm feeling better." Will that be real? Will that be something different? I do not know. But he said, my pain is better. That's why I started the magnet research for pain management. One I found, that's on my wrist, another on my body. When I talked to the manufacturer, he's an engineer. His wife is a physiotherapist in Australia. And they are interested about collaborating the magnet research. It's a new dimension and more, not the superficial, we are going to go for more depth. So that's why we were trying one collaboration I'm doing for the back pain that I'm doing by myself. One group of the students, they're doing the osteoarthritis knee, they're doing another patient with the Parkinson's disease in Spain, and I am planning to do some research with the Maryville University. And there are different, the way it does work, it does generate the pulse. And that pulse is going to be magnetic field actually. This magnetic field is going to go up to certain distance depending on the magnet. This magnet is different than the bipolar, this is the quadrupolar magnet. This quadrupolar magnet, when you put on the patient's surface, and you have to keep the magnets very close to the patient, the skin, and you tape it, or you use the Velcro and strap it, and about 2-3 hours every day, the patient, you should think about the patient, how the patient is feeling. There are several research published in the animal, in human, but nobody has talked about the translational research. So my thing, one group I might do the animal research, another group I can do the directly on the human. That will be my research. And we'll talk later more about the detail of the research plan. We are looking for the inflammation, whether it can reduce the inflammation, whether it can change the cytokines, whether it can change the interleukin pain, whether it can change the TNF alpha. Those are the cytokines, and they play a role because there are some research in vitro. They do the culture with the white blood cells. They use the lymphocytes as well as the monocytes. Those two they culture. They put the film on that one. They found that those are the relevant for the formation of the pro-inflammatory material, and they found the reduction in the fluid. So we are trying to look at that one in the real patients. See that one, it does work, and if it works, then we're going to first we're going to do the pilot studies. If it works, then we're going to do the full pleasure research. It will be very good because I do feel I have the experience. Right? I can tell, I can say that one you don't feel also the same thing.
Yeah, thank you, Professor Ghosh. So we'll definitely go ahead with, collaborate with you for research, and then we'll have a kind of a joint publication. And a few cases from India, a few cases from in Amity Universities, and few cases of your Maryville University. That will be doing well. Thank you so much, and then we'll do.
I will thank you very much for a excellent lecture. So, but I have some questions related to your second talk, which you just briefed that you had a magnet you put it on your wrist, which has you experiencing some pain. But then after putting that magnet, the maybe 3-4 hours or a whole day or half day, so it disappears. My question is that same experience I had also, because for my back pain I was going to pillar to post to get its remedy for the pain relief. So generally it happens only when you move, when you walk. But then, as many people advises, so here also people practices the magnet therapy. So I searched a shop and went there, and it is in Delhi, Noida. So he has kept. It's not bipolar. I do not know. General magnet is bipolar.
This is quadrupolar.
I thought is a unipolar.
Yeah.
Here is a quadrupolar, but it's a general magnet, but it's a high power magnet, round separate magnet. It is prepared for the therapy. Its radius is 2 inch or so, and then you have this big one. So you put that magnet. No, this is a magnet. This is a magnet, but this is a different magnet, which is a very heavy, and it's a bigger size. It's a 2.3 inches radius. So this is a bigger magnet and very heavy and it's a high power magnet. So I have put also below my eyes and back. It gave the relief. But what it happened that it doesn't go away, because the moment you put for an hour or two, you just put it. They generally advise for half an hour, but I put more than that. But it disappears. It goes, not disappears, but it goes 95%, you can say. But then after a while or by next day it moves, it comes back. So this is but then my question is related to being a scientist and researcher and molecular biologist, molecular oncologist rather. You do not know what is my specialization. So I'm an oncologist, a molecular oncologist, and cancer works on cancer, but tumor virology. There's a virus that causes cancer. So that cancer is related to women, the cervical cancer, genital cancer, which caused by a virus that is called human papillomavirus. And so that I worked on whole life. And I worked with a Nobel laureate who discovered this virus. He is no more in Germany, German Cancer Research Institute director. So, and he got the Nobel Prize for this discovery. So, but that is my story. I'm not telling that. But then what I am telling is that I am search for the mechanisms. So if you have, you are experienced person, and if you have any, I have not gone through all literature, but then it does give relief. But then what is the mechanism that the magnetic wave works on? That too, because it is a physiological or biological, you can say, the pain which is creating, it's a neural pain or nerve pain or any pain. It is pain created, and then particularly the nerve related pain. But then after using the magnet, what that magnetic rays or magnetism helps to cure the pain.
So the question is how this magnetic field is going to have effect in reducing the pain. Transcranial magnetic therapy is well established. That is for stimulating the brain area. So all of you probably know that one. Yeah. That is being established for keeping the patient with a stroke, a patient with the Parkinson's disease. We are doing the direct stimulation, and with the collaboration, I'm doing the collaboration with the Spain. So it is different. And here, when you use the quadrupolar magnet, so it does have some the magnetic field it is going to create. And one in the physics, the saw the Lorentz force. Lorentz force is that when you put the magnet, right, and the magnet, it is going to have some kind of the current. It can do and it has some kind of the one is the current, one is the field. And if you think about I don't know how many of you know still physics. So I'm talking about the physics about the magnetic. So you put the one is the current, so the vector of the magnetic field is here, and the force is this direction. So magnetic force, when it is given, and it's we have the iron within the body. This iron can be sodium, can be calcium, can be other iron, potassium. So this is going to those magnetic that Lorentz force is going to impact on those ions. And when the ions we do not know, that's our modulation. We do not know. We have that's why we are going to look for why we are getting the relief, whether this relief will be sustained, and how we are getting the pain. So this Lorentz force has some impact in movement of those charged ions within the. We are going to put the only magnet, not the whole body will be exposed to the magnetic field. On the area, in the muscle, in the area, in the joint, that area, try to reduce that one, that impact of those ions using the Lorentz force. Yeah.
Sir, I do have a question.
RPMS study and PhD.
Yeah.
Sir, on TMS. Sir, if we are talking about this pain, sir, then we are also aware of pain gate mechanism. Sir, do this magnet have any influence on that pain gate mechanism? Simultaneously, when this pain is conducted, it reaches thalamus. So, whether these magnets are this much strong that it is influencing that thalamic area in the brain? But what about central pain if we are talking about?
So pain is a different kind. For example, the thalamic pain is coming from the thalamus, the neuron. Some pain is a neuropathic pain, is the nervous system, is the nerve fiber. So if you think about the pain, the gate control is one, but you can think about the gate control is the fibers, different fibers, right? And the fibers are going to the substantia nigra, the substantia gelatinosa in the one, and it's coming from different fibers, the A delta or A beta fibers are going to control the gate. So these changes in the opening and the closing gate is all mediated by the neurotransmitter. And this neurotransmitter has to work with all the ions, right? They have to work. The depolarization is not the one fiber. There are synapses. The calcium is going to play a role, sodium is going to play a role, then the depolarization is going to start, then it's going to propagate. So, as I said, this Lorentz force is going to have some impact on those ionic movement, right? It may limit the movement of the ion. Therefore, if it limits the movement of the ion calcium, then what is going to happen? No neurotransmitter will be released. So pain is not going to propagate. So we do not know. Again, this can happen. We do not know. Nobody showed anything. But we know that Lorentz force can influence the ionic movement.
Like we are acting on peripheral system and we are modulating central pain.
Exactly. That we are modulating the transmission of the different pain pathways. If somebody has a pain coming from here in this thalamic pain because of the thalamic abnormalities, then it's a different situation. It may not work. But if the pain is coming from the periphery, anything and all, it may become something.
Thank you, sir.
Then we can compare to one thalamic stroke case just for a small case study. That will be superficially we can come to know how the pain reduction instead of the ion transmission. Yeah, so that we can
Again, that's another thing.
Yeah.
So, the perception of pain. You will not forget the change. The change has to take place in the periphery, right? And the perception, all the different descending pathway or pain modulation is going to take place at different level. But spinal cord is also there too. We can modulate there by changing the ionic things. Maybe some inflammatory material, interleukin, substance P, you do not know anything about.
Thank you, sir.
Yeah, it will be good. I know that. It will be good. it will be good because whenever I think about this one, and I have been in collaboration with the Australian, and we are trying to get more the different institute to get more different aspects of the painting. And I'm presenting some part in the World Conference in Tokyo this coming June. Next, please.
Thank you, Professor Ghosh, for sharing such a vast knowledge. Thank you for the wonderful presentation and demonstration too. I'd like to request our Dean Sir and Deputy Dean Sir, as well as Director Sir, to kindly felicitate our esteemed guest.
यहाँ ले आओ।
Great honor to have you, Dr. Ghosh.
Thank you. Thank you very much. Thank you.
I would like to request Dr. Neha Gupta, Associate Professor of IHAS, to please come and have the vote of thanks.
So, dear esteemed guests, dignitaries, and colleagues, I, Dr. Neha Gupta, I would like to extend my heartfelt gratitude to each and every one of you for making this event a resounding success. I would express my special thanks to our distinguished guests, Dr. Tanveer Nawed sir, Professor Dr. B.C. Das sir, Professor Dr. Chandradeep Tandon sir, and Dr. S.K. Srivastava sir for their insightful address and presence. Dr. Pradeep Ghosh, thank you for your enlightening presentation on gait training in individuals with stroke. The emphasis on importance of symmetric gait weight bearing in gait pattern training and particularly in early rehabilitation phase has resonated deeply with us. Additionally, the insights on the role of feedback, especially the visual, the audio, and the proprioceptive feedback, were truly invaluable. We would also like to appreciate the enthusiasm and dedication of the students of the Maryville University. Your participation has added perspectives to our discussion. Further, I would also like to thank the UG and the PG students of IHAS for their active participation, your patient hearing, your engagement and enthusiasm is truly commendable. Our today's event has marked an important milestone as an initiative towards the collaborative research project, which includes exploring innovative approaches such as the role of magnets in pain management. And this has really sparked interesting discussions and ideas. And we really look forward to fostering meaningful partnerships and advancing our knowledge in our respective fields. Further, I would also like to appreciate the efforts of our organizing committee, the faculty members, the staff who have worked tirelessly to make the scene and a smooth execution of this event. Thank you all once again for your participation and engagement. Thank you.
Okay, so we will have a break for 5 minutes, and after that, the research presentations and discussions will be there. Thank you.
Students, please You have just 5 minutes, and after 5 minutes, you have to be here back for the research presentations.
Yes, sir.
So my lecture is supposed to be there in the. Okay. So thank you all after the break. So once again, Professor Ghosh and your team, these few things from our side will be, along with my students' presentation on a few case studies, and that they can share later. So in my presentation, I'll just touch very few slides of this collection, as I don't have much time, because I'll just let others to speak. So I'm a sports medicine man. So sports ergonomics, I did my this PhD in ergonomics and my specialty in sports medicine. So that's why I just patch these two, the sports ergonomics, how the better performance of the athletes or players will be there. And we just put these ergonomic principles here in the sports, then to get better performance. I'll just touch 2 or 3 things here, including the nanomaterials used in sports equipments. This will be little small catchy. I'll just go very fast. This already we know the ergonomics is the laws of work and mostly the conservation of energy, minimum input, maximum output. This is the normal general ergonomics. And this micro level, I do not want to much discuss it. Yeah, this one I want to talk because we have the contribution to this field of ergonomics. The last one, I can see this making person fit to job. It was by us, Jaswant Sethi. I'm sorry, I didn't mention my 2 pioneers' name, Jaswant Sethi, Jaswal Singh Sandhu, and Vijay Menanthan. We 3 only the first time said where we got encountered by many people while published that later we got around 102 these citations out of it. See, this is the goal of the ergonomics, that is rather than making the person fit the job by ergotech. This is when something what you call, you are not doing something and don't do it. This is by Bill Black. And of course, the making the person fit to job, this is the past. By us in 2011, we just published it. And this we know the principles, of course, my students already studied in ergonomics, that's this common. And for your students also, maybe they might have studied it. So these are the benefits, of course, they may be knowing, and that's vertical in computer, this musculoskeletal discomforts, the type of injuries from muscle pain to musculoskeletal disorders in the discomforts in many aspects. These are the target regions, spine, neck, back, upper extremity, lower extremities. Then the few vertical tools, I just vertical put it here for your reference. From this OVAS, RIBA, ROLA, all this, okay, we day to day, we just use it for even this bachelor and master researches in physiotherapy. And the last one is the AMSDQ, just we put it past time and we copyrighted in India. I'm coming to this, my part, the sports ergonomics. Of course, this principle of ergonomics and to have inculcated to do the better performance with reducing this risk of injuries for the athletes. This is in the sports and physical activities, enhancing performance, improving safety. This is the really unchained for the first time. They in 1994 they just found out that ergonomic involvement in used materials, used
the sports products, how to be better, not only simply fitting, about the material properties and best with the strength and lightweight, which can have the benefit in their performance, not inhibiting their movements during the exhaling performance. These are the internal and external risk factors. Of course, that's in sports injuries. We just put it usually from this the is till this surface. That's both. I just put it from internal and external factors. Few are there in in this slide. That's external risk factors from the raised height. That's in the these physical attributes, requiring arm movement, heavy load, all these things. In internal contributions, again, physical attributes are this anthropometry, this gender, physical ability, personality, etc. Here I just put it, this ergonomics, mostly the principal ergonomics can be applied in the context of the sports and physical activities, as I said, to have the improvement of performance better. Then this biomechanism, physiology, and psychology, these three entities, okay, usually just put it. But along with that, this nanomaterials, what I'll just present in the article after a few of my slides, that has been inculcated, what the how this material properties is helping in the sports course. This appropriate training, yes, previously we used to concentrate on training and heavily training, much heavily training like that, but we need appropriate training not to have the muscle injuries or already exhaled forces are unnecessarily wasted. That means, for example, in the follow through, whatever the big energy is unnecessarily wasted, how can be compromised in a kind of training? And of course, the design, of course, in the effective equipments, as I discussed. Next is yes, this is the part we always just pinpoint it from my sports medicine times in 1999 onwards. The fitting the person to the task. Every time this one we just what you call stop it, because people they must do not use it. They say that keep on what you call putting it, keep on doing more and more. But we say no. That part is coming next. This is run up without a delivery. For example, suppose people suppose one athlete is doing a heavy run, but delivery is not there. Just come back. So that comes a big injury where the excess the end product of this lactic acid produced, but delivery is not there. But another one is excess follow through. The delivery is there, but high follow through, where wastage of the unnecessary energy, and later person is becoming weak. These two parts we want to just put it, touch it here. Next, coming to the spinal shrinkage, of course, from this embryo stage onwards, the most vertical like this is C-shape, and all these sports persons, mostly the sports persons are like this way. Just vertical. They have mostly the flexion type of things are there. But in ergonomics and anatomy, little difference is there. In anatomy, suppose you just go back, then come back to the original position. But ergonomic, we say no. Flexion, then normal, again go back to the extension. That's the difference in vertical. Little bit knowledge and requirement of this, where the principal ergonomics used or applied in the sports to have a compression of spine or anywhere in the joint identically. Say anterior compression always, and this vertical, the pectorals having the vertical more stronger, and the posture is like this, whereas these extensors or the back muscles or the posture completely having the inappropriate, or it's not simultaneously will have that much structural support or functional support in any kind of task. That's why they go prone to have many injuries. To stop this. So, as I said, the spinal shrinkage, this compression force in the anteriors, it's not that, don't think that it will go for more, that's kind of compressive fracture. No, not that. Unless there is a heavy load, those are doing this weightlifting in the gym is happened. If this identical load is given, this anterior, this lateral, and to this facet joints, then can have equal or the equilibrium or this percentage of the loading in anterior, lateral, this bilateral, the left lateral, right lateral, and posterior. That is what requirement is buying. And here the yoga postures. That means complete C-shaped extension, what is necessary, and exercises, strengthening exercises to have this this extension C-shape that required for spine, that's in cervical, thoracic, and lumbar. That will give a well ergonomic vertical division and the loading distribution proper, then can have big sustainability without wasting much energy and can have the better performance. These are again this same thing I just put it at the Cannon and James in 1984. They found it for the first time, and 7.6% of patients they have seen it, where the average this shrinkage rate 0.4 millimeter per minute. They have seen it in their study. This I'll just skip it. This is vertical spore surfaces. Of course, the very vertical, beautiful, this materials are nowadays they are the tops and the best materials are to have the better friction to can have, and at the same time, the type of shoes with the perfect spikes. Look at this. That can have a better friction to have the hold, can have this dynamic balance better, not to have a slippery at the fall or during have any this multi-joint injuries. So these are racket. I'm not going to discuss about that because it's very, they take long time about this racket out and the size, and they should be here from this this last article, this the second layer of the carpals to this past article, the thinner crease. That will be the ultimate circumference of the grief that must be there, but it's not nowadays not available, or is as per whatever is given in the or is sold in the market. Simply that what you call bringing it and taking. Plus, at the same time, they are not taking the materials properties and what materials of this nanomaterials are given. They don't have any knowledge. These are the, okay, of course, this clothes, the type of clothes and material properties of the clothes. This just type only one small point I just touched it, but not elaborately. This, okay, of course, after warm up, this cool down last one, this one. Then I'll just skip this one. I'll go directly to this. X 1 minute. Yeah. This is the impact of nanotechnology on sporting equipment. These are the degree of this competitiveness impacted this nanotechnology and has come up nowadays is a very good way to help the complete sports medicine team about not thinking simple the performance compatible with injuries. So these materials playing an important role. For that, we have to have a kind of information and knowledge. Then we can have better prevention of injuries, because once we get this in cases of the injuries and treating them from the vertical different degrees and making back to them to field is really difficult and takes time, because it's a matter of this flag of our nation, not our nation or any particular this countries of the flag. So that's why these are the things are there. Look at the advantages. The advantages of nanotechnology in the sports equipments: this reduced friction, enhanced durability, increased hardness, enhanced strength of the weight to the weight ratio, then reduced weight, wear resistance, resiliency. these few factors are helping. These nanomaterials are with these material properties of those spores equipments are built up with this. Example is here in 2009 that has been seen that this silica nanomaterials, nanoparticles were used by this Roger Federer. And next one is with this Oscar Pereira also had used this carbon nanomaterials, nanotubes for his cycles. So these few things thus given the good impact in the field of the spores to have lesser incoming injuries where we are unnecessarily dying with their injury treatment or taking long time. So these are the materials to have the information, this carbon, this silica, this polymerase, this nanoclay in the different fields of the spores and their benefits. So these are this activity related muscular dystrophy cell. This we have been first time we just put it and copyrighted it here in the Amity. Thank you so much. These are the few references we have put it from my PhD times, 1999 onwards. Thank you so much for a presence here. Any question? Thank you.
Thank you so much, sir, for delivering this presentation. I would like to request Dr. Sanjeev Kumar Das, Associate Professor, Department of Physiotherapy, Amity Institute of Health Allied Sciences, to deliver his presentation next. Thank you.
Second. Thank you, Dr. Ankita. I'm Dr. Sanjeev, and since we are in the exchange of knowledge, I would like to briefly share one of the recent publications in the safety science in the Elsevier publishers, where the study has been conducted with relation to model. So we have modeled the risk factors, and these risk factors are related to WMSDs, work-related musculoskeletal disorders, particularly to an occupations, medical practitioners. So in the recent or in the last few decades, the growing globalization or industrialization, it has been seen that the occupation-related health issues has been very significant, and it is creating a real issue to the workforce. The studies are there, which is also stating that the occupational safety and health has been, have a relation in the physical and the occupational factors. And that is a pathogenesis for WMSDs, work-related musculoskeletal disorders. So what we try to see here is that these WMSDs, which is a constant problem, not only to our country, but all over the world, and creating an economic burden, reducing the quality of life. So this is also prevalent in the healthcare fraternity, medical staffs. So in the present research, we have tried to find out the potential risk factors and an extensive literature survey conducted. A Delphi methodology was applied, and potential risk factors after assessing it. We have the ISM methodology, interpretive structural modeling methodology, so that we can find out what is the driving power, what is the dependence power of these risk factors. Then we have measured the risk factors' influence over any other risk factors or codependence through a MIC-MAC analysis. And why we have done this? So that we can have an understanding of this interrelationship, and it will help the healthcare organizations to prioritize any policies or to help the manforce to successfully attenuate these WMSDs. So these are where our research objectives, where we to identify the potential risk factors, investigate the interrelationship between these risk factors, analyze the influence or any codependence of these established risk factors, and finally to strategize any mitigations of these risk factors. So coming to this flow chart, as you can see in this flow chart, the risk factors were identified with the help of extensive literature survey, and then experts' opinion were taken, specialized medical practitioners, and then we went to define and determine the contextual relationship among the elements. Then these experts were asked to make some pairwise comparison, which helped us to develop a reachability matrix, which we call as initial reachability matrix. And from there, we have able to create the final reachability matrix. This final reachability matrix was also carried out before making a transitivity. I'll talk about that later. And then we have developed a conical matrix, and finally a digraph based on that. And the end, we have categorized 4 quadrants where we have placed these risk factors as autonomous, dependent, linkage, and independent with the help of MIC-MAC analysis. So as I mentioned, 25 experts were taken and they were given a scale of 1 to 7. They were asked to please have the measurement of the risk factors, the potential risk factors, as 1 as least important, 7 as the most important, and those scores less than geometric mean 4 were removed. So finally, we have come up with the 8 potential risk factors, as you can see in the slide. Static postures, prolonged static postures, definitely due to physical load. There has to be a stationary posture, repetitive tasks, or prolonged exposure to a given task where the practitioners were bending the trunk and the neck and possibly having neck and back pain. Awkward postures, particularly when they are in the wards rounds, when they are in consultations or they are writing reports. Job satisfaction, particularly to tell here as dissatisfaction because of the long working hours, long shifts, job related fatigue. Time and work demands, because since they are in the long working hours, it is affecting their work-life balance. Organization culture, where the physical work environment, where there is a very low or social cohesiveness, so that can create the musculoskeletal complaints. And the last risk factor, work-related stress, because of the job demands, patient expectations, interruptions, work-home interface, social life, coping with disease and dying. So these all might create physical and psychosocial stress. India, where the population is more than 140 crores, we have a patient-doctor ratio much lower. And in such cases, they definitely undergoes work-related stress. So once we have done with the risk factors, we give a structured questionnaire to these experts and ask them to put a relationship in the variables. How? So we then ask them to make a pairwise comparison. So by denoting VAXO. So V is here where there is a direct relationship. You can see I and J factor. I is where it is the rows, J is where it is columns. So direct relationship means the barrier I or the factor I helps in achieving the barrier J. Where the A denotes for inverse relationship, that is J is helping to achieve the barrier I. X denotes a mutual relationship, that is I and J is helping each other to achieve, and O relates, there is no relationship actually. So here, with the help of this denotions, we have made this self-interaction matrix. I can give some examples here, like one of the examples, the R1 is having a direct relationship with R5. That means prolonged static postures is having a relationship with job satisfaction, right? That means prolonged static posture can create dissatisfaction. So we have denoted V. So similarly, all other A, X, O has been denoted accordingly. So from there, we have underwent the initial reachability matrix. It is from the denotions of VAXO. The information has been changed into binary digits, as you can see here. And then we have come up to a final reachability matrix, which is in the next slide. In this final reachability matrix, before going to that, we have checked transitivity. Transitivity is where a concept or a presumption that I is related to J, and if J is related to K, then I will be related to K. So accordingly, this is the final reachability matrix, as you can see. We have also able to define here the driving power, the dependence power. So if you can see in the slide, the dependence power, the greatest is the R1. Oh, sorry, it is R5 here and R8. So R5 means the job satisfaction and R8 means work-related stress. So they are the most dependent risk factors among all other risk factors. And then we have developed this conical matrix where we have basically synchronized the dependence and the driving powers. As I mentioned, job satisfaction or work-related stress are mostly dependent on all other risk factors. Similarly, the driving power is also there. They have been also synchronized. So from based on this, we have finally made a diagram. As you can see in this diagram, the findings shows the organization level factors like repetitive tasks and the organization culture. They are having the highest driving power, and they are followed by prolonged exposure to a given task and time and work demands. So, and these organization level factors are again driving the physical factors. So here the physical factors are prolonged static postures and awkward postures, which is again driving the job related factors, that is work related stress and job satisfaction. Based on this dependence and the driving factors, we have plotted the XY axis. It is called micmac analysis. There are 4 quadrants. The first quadrant, we have not put any factors because no factor is dependent or independent or related with the other. The second one, we have put 2 factors, job satisfaction and work-related stress, because they are having highly dependence power. The third quadrant, where it is unstable and they influence others, we have put the awkward postures and prolonged static postures. And in the fourth quadrant, the rest of the factors. So the name of these factors, the name of the quadrants are autonomous, dependent, linkage, and independent. So from here, we have finally proposed a mitigation strategy. So these risk factors, like there is a prolonged exposure to a given task. So a breaks can be given. Time and work demands, time management, even to the doctors, they require time management training. Repetitive task, a few stretches, okay, even endurance training, muscle strengthening. Organization culture, stress management is required. Prolonged static posture and awkward postures. Even the doctors who are advising the patients, they has to be advised that please have a neutral posture. While you are seeing the patients, have alternate movement. One time patient at the left, another time the patient at the right. They can have anti-fatigue mats while using the operation theater tables. It can be adjustable, chairs can be adjustable, instruments can be adjustable. And of course, the BMI, it has to be also maintained because it can affect the, okay, have a loading over the lower limbs. Job satisfaction and work-related stress. So they had to be taught with stress audits and counseled. I'm talking about the doctors. They has to be also counseled. Then workshops related with relaxation, how to do relaxation. And also policies were not more than a certain working hours. So I conclude here that this model, which has able to define the potential risk factors, so they can be helpful in formulation of ergonomic adaptations, alleviating the risk factors, and definitely it will able to reduce the WMSDs, work-related musculoskeletal disorders. Thank you. Any questions? Okay, thank you.
Thank you, Dr. S.K. Das. Going ahead, I would like to call Dr. Satyajit Tripathi, who is going to share his information on neuroinflammation. Thank you, sir.
Okay. Good afternoon, everyone. I hope you are all enjoying the lectures. Now I am going to discuss on neural inflammation, consequence of cerebral infarction. I know you have listened about the stroke and how it is controlled by the human being, right? Till now, and how any difficulties is controlled by the human being. But here I am going to discuss about the stroke, which is controlled by the human body itself. And mainly I am focusing on cerebral infarction. We know the stroke, that is third leading cause of death and disability worldwide. It's not related only with the blood vessels. It's also affects on the neurovascular unit, that is glial cells, and matrix metalloproteinase, vascular cells. Those are related during neuroinflammation. And this neuroinflammation occurs during the acute phase of stroke, which is associated with the blood-brain barrier breakdown, neuronal injury, and neurological outcomes. You can see here different stages of stroke. And we will focus here only blood-brain barrier disruption and inflammation. But before it, we will have to know about the arrangements or components of the blood-brain barrier. Our brain, which is very sophisticated region of the body and which is very or critically protected by the body, right? But you won't find cytokines, but you will find very rare cytokines. Our body protection system is inflammation, immunity, inflammation, cytokines. But our most protected area is in a protected area, you will find rare cytokines. But then how neuroinflammation is occurring or happening after stroke? So first we will have to focus on the blood-brain barrier, which is composed with, you will find microglia, that is called brain macrophage, astrocyte, pericytes, and in lumen you will find glycocalyx. Glycocalyx is attached with the, glycocalyx is attached with the endothelial cells, and neuronal end. You will find here in the picture that tight junctions are here. These endothelial cells seals the lumen and glycocalyx. Okay, and it's protect from intervention of peripheral immune cells. Okay, so after stroke, what happened? These blood-brain barrier disrupts, and the peripheral immune cells. What are the peripheral immune cells? We know at neutrophils, macrophages, which are present in our body but not present in our brain. So it intervenes when this blood-brain barrier disrupts due to the stroke. Okay. So here perivascular macrophages are key mediator in immune surveillance and are located in penetrating arterioles and postcapillaries venules. The glycocalyx, you will find here the glycocalyx, it's showing here like that, but it is a gel-like structure. in the lumen with the endothelial cell layer, the glycocalyx present, and it is situated luminal site in endothelial cells composed of proteoglycans, and they are linked of GAC chains, including heparin sulfate, hyaluron, you know all. And this glycocalyx degranulation or degradation and shedding dramatically increase blood-brain barrier permeability. This glycocalyx shedding causes the blood-brain barrier permeability. Now we will have to check on the tight junction. If we emphasize, you will find here that endothelial cells are connected to the tight junction and adherent junctions. In tight junction, you will find protein proteins and also occludin proteins, which are associated with others zonular occludens proteins. And in adherent junction, you will find different cadherin proteins. Okay. So this cadherin, vascular endothelial cadherin and catenins are the main structure proteins comprising the adherent junction. And they are necessary to form tight junction and provide physical integrity of the blood-brain barrier. Why I am discussing about this junction, tight junction, adherent junction, these are very important to maintain the normal homeostasis of our brain. When these tight junction or adherent junctions disrupt, when this blood-brain barrier disrupts, then the neuroinflammation occurs. In initial shock, initial stroke, inflammation causes. But if this shock or strokes is not able to damage the blood-brain barrier, then it will be helpful for us. But if blood-brain barrier disrupts, then it will be very harmful for us. So now we will have to know what are the key pathological events and pathways fueling neuroinflammation. In scheme, you will find exocytosis and oxidative stress, which mainly, I already discussed about the astrocyte, microglia, which are remain in the brain, blood-brain barrier cells, which are one of the components of the blood-brain barrier. When initial strokes happen or shock happen, then what will happen? It activates the exocytotoxicity and oxidative stress. I hope you have all idea about the oxidative stress. Now, exocytotoxicity, I will discuss later. This exocytotoxicity and oxidative stress activates these microglial cells and astrocyte, which releases the inflammatory factors. In brain, there are also inflammatory factors, inflammatory cytokines. And then what happens? These inflammatory factors activate cadherin proteins or adhesion molecules, ICAM, mainly ICAM1, which upregulation of this ICAM1 causes the disruption of the blood-brain barrier. Means helps to penetrate the peripheral neuronal cells into the blood-brain barrier, through the blood-brain barrier. Okay. Now, exocytotoxicity, which is cause major due to the ATP depletion and phosphocreatine depletion. You know phosphocreatine, which regenerates the ATP. Excess ATP depletion causes the exocytotoxicity, and which helps the upregulation or overloading of the potassium, and gradually it's activate the NMDA receptor. The activation or upregulation or overstimulation, you can tell that NMDA receptor raises these things, calpain activation, this signaling pathway, very devastating pathway, which causes the cell death, neuronal cell death, and calcium overloading and NOS activation. You know, nitrogen oxidative stress, NOS activation, which consequently causes mitochondrial dysfunction. And this mitochondrial dysfunction causes release of apoptotic factor and apoptosis. One thing I am telling, these things I am talking about the neuroinflammation which causes harmful effect of in our body, right, in our brain. But this mitochondrial dysfunction or mitochondrial stress also causes beneficial role for the shock. There are many reports, but it depends upon the certain level, up to the certain level. Okay, next, this overloading of calcium causes the glutamate upregulation or glutamate overloading. And this extracellular glutamate also activates AMPA and metabotropic glutamate receptor, you know, which is critical step in inflammatory cascade. This is the schematic presentation where you will find that I already discussed about the NMDR in last slide. Here, AMPER and metabotropic receptor, which results overloading of the cytosolic calcium, and consequently it results superoxide radical generation, protease activation, and ultimately oxidative stress, apoptotic factor activation, apoptosis, and neuronal death. I am talking when shock happens after that, means once shock happened, after that it's happening. But in normal condition, it may happen. No, it doesn't happen. NMDR upregulation doesn't happen because there are magnesium ion which blocks it. But due to the activation of NMDR and you can tell overloading of the calcium ion, which removes the magnesium ion. And the consequence is that now oxidative stress, mainly xanthine oxidase and NADPH oxidase are the two key oxidative enzymes that play major role in the production of superoxide anion. Hydroxy radical also responsible, which elevated after 2 hours of the stroke. Nitric oxide also another key radical. You know this nitric oxide have the beneficial role after stroke or shock. But when it acts with the superoxide radical, it causes damage. Next, Next, this schematic presentation you can see here. This due to the injury, what happened? Damage associated molecular proteins that may be amyloid B, fibrinogen, and mitochondrial factor cytochrome C, which activates the transcription factor for the apoptosis through the NF-kappa B, AP1, MAPK, ERK, and here pattern recognition receptor signaling also involved, and it causes the NOX2 activation and results oxidative stress. Another factor, key pathological event, that is MMP activation. MMP activation also disrupts the blood-brain barrier. You know the pro-MMP12, which is present by the autolytic processing, which MMP12 activates the MMP9 and MMP3, MMP2, all the MMP matrix metalloproteinase, which all together degrade the PCM and also tight junction. So what we came to know, you will find that initial ischemic event leads to oxidative stress and causes leads to oxidative stress and excitosis, which causes activation of microglia and astrocyte, resulting in the secretion of cytokines MMP and GFAP. And after that, what happened? The pro-inflammatory factors upregulate the ICAM, and which derive the inflammatory cells such as neutrophils, macrophages, and lymphocytes from the blood, from the body. And in addition, dams are related by dying neurons that in turn activates microglia and peripheral lymphocyte, resulting in production of pro-inflammatory factors. What happened? First, initial ischemic shock happened, and then what? Astrocyte, microglia, those has been activated, and which secretes the inflammatory factors. Okay, and these inflammatory factors disrupt the blood-brain barrier, and disruption of blood-brain barrier allows the peripheral immune cells to enter into the brain. Okay, and these immune cells release more cytokines and causes more inflammation, and these cycles repeats one more, because after these inflammatory cytokines releasing in the brain by the peripheral immune cells, the brain damage and damaged brain again activate the astrocyte and microglia. So this is the cycle, and that's why stroke, after one stroke, it longer more than 10 years, 12 years, up to that. This is the cyclic incidence or cascade you can tell. There are mainly the three cytokines which is released by the inflammatory cells. There are TNF alpha, IL-6 and IL-1 beta. These cytokines are the pro-inflammatory cytokines which causes inflammation, neuroinflammation. There are many reports that TNF alpha peaks up to 15 months, remains up to 15 months after the 2 hours or 3 hours shocks in the body. Not only in the brain, also in the plasma level. In plasma level also you will find the TNF alpha. And there are IL-1 beta, you will find in CSA plasma level, IL-6 also there. And alternatively, as I am talking about the neuroinflammation, which is repeating and which causes the neuronal cell death or brain damage. So it's happening by the neuroinflammatory cells or neuroinflammatory cytokines. If we treat the anti-inflammatory cytokines, of course it works, but the study is not standardized yet. But it has been found in some in vivo study that antioxidant enzymes can treat. Okay, however, other cytokines also contribute to brain damage and repair, but the balance between the beneficial and detrimental effects of cytokines largely depends on the biochemical and physiochemical status of the brain. Till now, I am talking about the inflammatory cytokines, inflammatory cells which have the detrimental effect. But these cells have the beneficial effects also. Means it depends upon the degree of shock or degree of damage. Okay. So this is the scheme and summary. You can tell what I discussed about the neuroinflammation. Main point is disruption of the blood-brain barrier and interventions of the peripheral immune cells into the brain and releasing of the cytokines, more cytokines, which repeats and causes more damage into the brain and results in the neuroinflammation. These are the source. Thank you. Any question?
Thank you, Dr. Tripathi. I would like to call Dr. Vidushi Sharma from Department of Occupational Therapy to give presentation on independence in ADLs.
Thank you, Dr. Ankita. Very warm welcome to the students of Maryville University. Tired? Hungry? So I won't take much time. So let me just hurry it up. So my topic is moving towards independence in ADL through FES in spinal cord injury patients. So here we know that FES is a subtype of neuromuscular electrical stimulation in which it assists in functional and purposeful movements. So here we are trying to achieve functions like lifting a book from the desk or bringing a bottle of water to the mouth or holding a pen to write. So all these activities in spinal cord injury patients due to the paralysis are not achieved. So FES is one of the solutions which are researched. Some of them are FDA approved as well. So just highlighting few of those aspects. So when you say an FES system which facilitates a specific movement related to a function, then it is also called as neuroprosthesis. So it would help you in training your patient to grasp objects of different contours and size and shapes, and also help in standing, walking, reaching, and other activities. So it is dependent over the philosophy behind development of any neuroprosthesis based on the neuroplasticity principles. So it has been hypothesized that electrical stimulation with descending motor command is essential for beneficial neuroplastic changes. And when the stimulation above a motor threshold increases the excitability of corticomotor pathways, which can be done through stimulating sensory axon and recruiting synaptic motor neurons and motor reflexes. So this would have changes in the cortex level, and neuroplastic changes can be incorporated. So with physiotherapy and occupational therapy in spinal cord injury patients, we have to do the training with the neuroprosthesis. So these are again the cortical plasticity based principles. Basically, they are talking about encouraging sensory motor activity in the patient, doing sensory stimulation, somatosensory stimulation, which would create cortical plasticity in the spinal cord injury patients. So motor training consisting of voluntary movement. So here they are emphasizing this is something which requires an active involvement, high motivation among the patient to be able to perform with the neuroprosthesis. If it is done more passively and the patient is not much motivated, we tend to see not very good results with the patient. So when you're recommending something so expensive, you have to really judge that the patient can, how much active participation does the patient have to use that. So voluntary drive would facilitate CNS excitability. So these are few of the things you need to consider. The sensory threshold of the patient, motor threshold, what is his maximum tolerable capacity, and what is the operational stimulation intensity, that is the actual dose of the stimulation that you are deciding for your patient. You should be checking for these precaution consideration and these conditions in your patient. And poor skin conditions like pressure injuries, poorly controlled epilepsy, if the patient is having, then avoid using FES. And history of autonomic dysreflexia, which you would see in the patients who have T6 above level injury. So avoid FES, pregnancy, cardiac pacemakers, cancerous tumors, if they are exposed metals anywhere, unhealed fractures. If you are suspecting also that the patient might have some cardiac condition, you should always monitor your patient pulse rate, heart rate during the therapy and after pre and post therapy session, so that if you suspect some cardiovascular condition, then you must avoid FES kind of stimulation. And if the patient is using botulinum toxin, so with consideration of your neuro physician and the neurosurgeon, you should proceed with utilizing FES. So there are many FES you can see here. For grasping, there is system by Rebusek and Vodovnik, and then NES H200, which is also FDA approved, most commonly used one. Bionic glove is another new project, and freehand system is implanted type of FES. That's not surface. It's not just that you would put it on the surface and do the stimulation. This is one of the system which is to be implanted. So you need to be putting the patient under the knife. So another for reaching and grasping is Belgrade reaching grasping system, complex motion neuroprosthesis for reaching and grasping, and mind move. So among all of this, the FDA approved ones are NES H200 and mind move. Maybe your organization is having any of these? Yeah, no, no idea. So you should discuss with your faculties as well. Maybe that would be helpful. So NES H200, as we have already seen, that it helps in grasping, stimulating finger extensors and flexors as well as thumb. And this is FDA approved H200 by Bioness company in US. Bionic glove is another one which is designed for individuals with SCI who have active wrist flexion and extension. At least to use this, patient shall have some active wrist finger and wrist flexion and extension. So it is operated with a similar concept of tenodesis grasp. So just like in tenodesis, the extension would help in grasping and the flexion would help in release. The similar kind of concept would be utilized. The bionic glove further aids in the kind of contraction, that is the grasping which is happening and the release which is happening, the timely and the strength wise. It gives more support to the patient to perform this activity smoothly. The freehand system, which is the implanted one. So basically here one of the electrode is implanted in the area which is intact, which has intact sensory functions and used to provide sensory feedback to the users. So mostly the intact side or intact area in the same limb, that gets the one of the implantation, and activation of that area would send the signal to the affected portion to do the contraction or muscle contraction. So here one example is given. The user could activate the device with the movement of wrist or opposite shoulder, which were detected with motion sensor mounted externally. Okay, so different positions of shoulder could be used to trigger hand opening, closing, and fast shoulder movements allowed the user to sustain stimulation until the next fast movement. So this is also one of the FDA approved and commercialized through Neurocontrol Corporation. this is something which is happening during our sessions in the therapy. You must have seen already. So there are various research evidences supporting the use of bionic glove or FAST, and results have been seen to be quite significantly good for C4, C7 level in complete chronic stage SCI for even more than 24 months after injury. That means the carryover, the transfer of learning, it has a longer duration of sustainability. So protocols have been developed to encourage palmar grasp, lateral grasp, tripod grasp, two-finger opposition, lateral pinch, lumbrical grips. Along with that, reaching is also been encouraged through sideways reaching and hand opening, sideways reaching and retrieving objects, and reaching over to the opposite shoulder, like you wear your shirt, so you need to reach over the opposite shoulder. So like that, many such activities are possible by utilizing these kind of neuroprosthesis. So basically, you need to consider what is your goal. Are you going to help him in increasing comfort? That is, reduce the pain factor, or decrease the electrical bleed, or minimize fatigue, or you want to improve the quality of tetany, that is the muscle contraction which you want to achieve. So as per that, the frequency, pulse width and intensity keeps changing. So these are again the research evidences supporting the use of FES. Certain limitations: there should not be a major degree of lower motor neuron injury or nerve root damage of the stimulated muscle. In a number of patients with SCI, there are maybe a variable number of peripheral nerve damage which has occurred, and that restricts the use of FES. So when you're prescribing FES, ensure that the patient is not having a lot of peripheral nerve damage. Cognitive ability of the patient: it may be like he might be working in a good company before injury, but if he is hospitalized for very long time, his cognitive capacity reduces over time because he's not utilizing the cognitive capacity. So ensure when you are giving that training, does he have enough cognitive ability to do that kind of active movement, which is part of therapy? Check that. And that cannot be done through using MOCA or MMSE. Those are the severe cognitive issues, but obvious. But then the functional cognitive problems should not be overlooked because of the long-term hospitalization and trauma and stress, anxiety, of course. Systems that do not have neuroplasticity and neuromodulation in their indication for use defined by the regulatory body should also be avoided. So ensure that the equipment that you're using for the training, it should be FDA approved. Okay. So thank you for your attention.
Thank you so much, Dr. Vidushi. We loved the presentation. And any questions from your side? Do people want to ask anything? So going ahead in today's program, our students from Masters of Physiotherapy and Masters of Occupational Therapy are going to interact with you all. They have prepared certain case studies which they have seen here in Amity University clinics or some other clinics as well. So they'll be showing you the case studies, and you people can, give your inputs. Now, this is not a one-way conversation which is going to happen now. You people can give your inputs, like how you see those patients, what different things you people apply to those patients in the rehabilitation protocol, so that we can have a good interaction and you can learn something, they can also learn something from you. Thank you. So I'll call our first student from Masters of Physiotherapy, Miss Sania Kapoor. Sania, please come here.
अरे सर ये वो है, आपको केस स्टडी अलग से भेज देंगे. एसबी चलो ये नहीं. जब वो लिंक के लिए बोले ना तुम आप आ जाइए. Good afternoon, all. I'm Sanya Kapoor from Neurospecialization. I've seen a case in IBS hospital, and I would like to share that case study with you. This case study is a non-myelomeningocele patient. So, do you know what's the pathophysiology behind myelomeningocele? You know about that? Okay. So, my patient, I have not revealed her name. She was 34 years old, female, from Amritsar, Punjab, and she is a tutor. Um, I have taken this assessment on 28th of September in 2024. This patient has a chief complaint of having difficulty in walking because of her poor balance. Along with that, she was not able to hold anything because of a poor grip, and she was not able to maintain a balance after coming from standing to sitting position or from sitting to standing position. This was her history of present illness. When she came in this IBS hospital, she was having this problem, and also she also had a complaint of less sensation in her left arm dorsal side. This was her past history. So basically, when she was 4 months old, she had a surgery of a lumbosacral lipoma, and another surgery was happened when she was only of 10 years old. Then she presented a deformity of ankle, that was a foot drop, and after that also she got a surgery of that. She presented a symptom. She presented symptoms of progressive weakness in her both lower limbs, and in 2022, she had a diagnosis of chikungunya that basically aggravated or exaggerated her symptoms. Because of that, that progressive nature of her weakness came more become more increased, and then after that she got her MRI, and she was diagnosed with cervical syringe at the level of C5 and C6 in both, and yeah, and it leads to the weakness in both lower limbs and right hand. This was a surgical history. The corrective surgery of that lumbosacral lipoma was done in Batra Hospital in 1990 in Mehrauli, India. The follow-up surgery was done in 2000 in GB Pan, New Delhi. The corrective surgery of that ankle foot drop was done in 2012 in Amandeep Hospital, and that cervical syringe removal was done in C5 was done in 2022 in Delhi only for the removal from the removal of C5 and C6 cervical syrinx. There was no significant family history of any serious illnesses. She was the only child. This was an observation. You can see there are some scars present that was horizontal, and there was a scar that was present in T10, T10, T11 level. This was a scar from the first surgery that happened. Then there was a scar from the callositis. You know what is callositis? You all know that? It's a formation of a callus, and that callus was painful. That's why it will get removed. Then this is the general observation that you can see. There was a splay foot. You know what is splay foot? Splay foot is a abnormal orientation of our toes. You can see that. Okay. Then when she came, she had an external aid that was AFO, and after that she was given knee gaiters. This was her posture. The posture shows that there was a retraction in the shoulders, lumbar lordosis, functional scoliosis, anterior pelvic tilt, and left pelvis was posteriorly rotated. Her build was endomorphic, and the gait was circumductory. This was the examination that I've done. For sensory examination, I've used brush, cotton pin for light touch and pain, and her dermatol level of C7 and C8 was affected. That's why she was not able to sense any sensation over her left arm. The motor examination, I've taken the MMT. All the muscle strength was okay, but she was not having a good reading in her left lower limb. So this was the if you want to see the reading, I can show you, or it's fine. It's fine. This was the ROM that I've taken. These are the readings of that, of upper and lower limb. This was a tone that I have taken according to the modified Ashworth scale. So these are the readings. This is the limb length discrepancy that I have measured, and we measured it through, you know the method, or should I explain it? You know the method? Okay. The balance that I have taken, I have used BBS scoring, and her scoring was 42 on 56. Earlier, when she came here, it was 22 by 56, but after her rehabilitation, it got improved to 42 on 56. Her gait assessment was done on the basis of TUG, time up and go test, and that was the reading, 68 seconds. Reflex testing, I've done all the reflex testing, except the Bibinski was not measured in her left lower limb, left ankle, because I have told you it was fixed. ADL assessment, Bathel assessment, basically it's an assessment for ADLs, that activity of daily living. For 95 to 100, it means that it is financial, physically the patient is independent. From 60 to 95, that means the patient needs somewhat of the support. When she came earlier, it was 55. She was not able to do any work by herself, but after the rehabilitation, her score improvised to 75. Hand girth, because I have mentioned there was a deformity in her left arm, so I have also measured that. This was the grip. Now, the goals. The short-term goals was to improve her posture, was to improve the balance, both static and dynamic. Along with that, we really want her to do her ADLs by her hand. So that was included in the short-term goals. And in the long-term goals, maintaining her strength and balance was continued in all her follow-up program also, to better her gait pattern and to maintain the hand function. This was a long-term pattern. The treatment, first the Cyberdyne was given. Do you know about Cyberdyne? Basically, Cyberdyne is a hybrid assisted limb instrument that is a exoskeleton present. The patient is aligned along with that, and they are trained according to them, according to the gait pattern they are following. It will sense it and it will assist the patient to walk and to improve the gait. It was given 6 days per week. This was Luna. Basically, Luna is a EMG. It is following the robot. No, it is a robotic device that helps in rehabilitation of both neurological and orthopedic patient. It uses EMG to help the patient to improvise their range of motion and muscle strength along with the neuromuscular facilitation. This was a gait pattern, and this is the video that is showing that how her gait training was happening with stick along with the AFO and gaiters. This was the another exercises that I'm following for a core strengthening. For kneeling and planks was done. Tymo, Vibra move. These are again the robotic assistive devices that is used. The Vibra move basically is a device that you can use for the proprioceptive neuromuscular facilitation to the patient. It will enhance their ADLs. So Vibra was given. Manual exercises was prescribed to her. Chattanooga, that is used for the stimulation. For her foot drop, for her hand, it was given. And bridging exercise crutches were done. These are the references. Thank you. Any questions? Thank you.
It's not a big question. I might have missed it. I was just, when you did like range of motion, are you looking at active or passive? Like, I don't.
This was an active reading.
This was active. How was like passive range of motion for upper extremity versus lower extremity?
You're talking about the readings?
Like, yeah, well, so like if that was active range of motion, passively, did she have more range in any joint, just passively?
her all ranges were absolutely normal,
Yeah.
except her ankle, left ankle. So I did not put the readings of passive R1. I've just shown the active R1 because all were normal. If you want me to show you.
Oh, no, it's okay. Thank you. I was just wondering. Thank you.
Hope you people are also treating your patients like this. Okay, so next I would like to call Miss Harsmita. She is going to talk about a case on ACL reconstruction. TCAR, yeah. So total knee replacement. There is a case which she is going to show you. Please come.
Good afternoon, everyone. Myself, Hashmita Tekchandani. I'm doing my master's in orthopedics and traumatology, and we are in SEM 2. The case I'm going to present is on total knee arthroplasty, which is a very common surgery today in today's life, where people are generally affected with OA. My patient was 66 years old female. She's a retired person now, and she lives in Faridabad. Her chief complaints after surgery when she came was pain and stiffness in the knee, difficulty with standing up, sitting down, and doing her regular activities. Long duration standing was difficult for her. She was complaining of not able to do her household work and the kitchen work that females do here. The history of present illness is presented as the patient went under total knee replacement on 25th of August, and post 1.5 months of her surgery she came back to the clinic, and she presented with stiffness and pain in her knee and was complaining of continuously increasing the pain and was not able to take the load on her knees. She was struggling with performing household activities and her daily life activities. Past medical history includes left knee osteoarthritis, grade 4, which was diagnosed 3 years ago. She started doing her exercises and later she went under surgery. The details of the surgeries are given. The surgery was conducted on 25th of August. She was discharged on 29th of August, and it was only in the left knee. Right knee was not that much affected. It was grade 2 probably. Pharmacological history includes her current medication that she takes, antibiotics, her vitamin D or the supplements. Her ibuprofen was SOS. Whenever the pain reoccurred, she used to take one. Social history includes her occupation. She's retired now and she stays in a family with her children, and the family is very supportive. Living conditions are very comfortable for her. She lives on the ground floor, so there's no stress of stair climbing again. Environmental history includes her home environment and the workplace of the community, where she is very free and is accommodates mobility aids and all the post-surgical things are to be taken care. Psychological history includes how she relaxes herself. Her family is quite supportive and social interaction maintains with supportive social circle. Pain history shows the pain started initially it was post surgery, 1.5 months after surgery. Also, she was feeling pain and stiffness continuously. Her anterior and the medial side were more painful compared to the lateral side of the knee. Aggravating factors were walking, standing, and when she was resting and elevated her knee on the table or a chair in the front, it relieved it. The type of pain was dull aching. The VAS, that is visual analog scale that we took, we asked her, and it was 3 at rest and 7 during activity. Postural and physical examination that I observed were general condition. She was overweight. Gait was slightly antalgic, and due to the surgery, she was carrying a cane with her. Swelling was present, and a scar of the surgery was present. Palpation showed tenderness, which is grade 2. Patient winced at once. Temperature was normal, muscle tone was normal. Uh, Range of motion, the ranges have been given. The operated knee was restricted to 90 degrees in flexion, restricted to -5 in extension. That is, there was a little of flexed knee continuously while she walked. Internal rotation and external rotation were affected, but not that much. Moving on to strength, and the non-operated knee was quite strength. Quite strong to take the load of the left knee, but left knee individually where quadriceps and hamstrings were weak, as you can see in the table. Hip flexors and calves were weak, but not that much. It was okayish. Then later, the patient when complained of balance and stiffness, I took this Berg balance scale assessment. The scorings are given, and the total score presented was 23 on 56. 21 to 40 is a moderate balance impairment where we need to really work on her balance and proprioception because it was concerning her standing activities. Functional assessment that considered her walking long distances, climbing stairs, carrying objects, sitting on for prolonged periods, getting up from chair, bending down, dressing her lower body, balance and stability. You can again see here balance, stability, gait, mobility, and bending down was severely affected. Getting up from chair was affected as well. The investigation, this was post X-rays taken post the surgery. So we need to condition the knee before. Goals of the treatment. These are the basic goals, that is pain management, improving range of motion, strength, functional mobility, and educating the patient about the ergonomics. The treatment plan, this is divided into 4 phases, where the acute phase includes the phase which is directly after the surgery. Then we will go to subacute phase and then the maintenance and the rehabilitation phase. The phase 1, that is 0 to 2 weeks, was pain management and swelling reduction, the basic RICE protocol that we follow, rest, elevation, compression, and ice application. Assistive device, she already uses cane, but sometimes when she has to go for long walks in the garden or something, she uses walker also. Early range of motion exercises that included passive and passive knee flexion exercises, where I used to help her with the flexion activities, heel slides and quadriceps isometric exercises with lesser counts and lesser hold. Then when we started muscle activation, that included isometric quadricep contraction and ankle pumps along with ankle isometrics. Phase 2 we come to, that is subacute phase, which long for 2 to 4 weeks, and this included more of knee flexion exercises, increasing the flexion of the knee, seated knee extensions, hamstring stretching and calf stretching, mild stretching in the initial stages. Strengthening exercises will increase the isometric repetitions and the counts, static hip abduction, straight leg raises, and seated calf raises. Weight bearing progression, we'll start with 4-pole, 3-pointer, and then we'll move further. Progressive walking, first we made her walk for short distances, shorter duration, then we made her walk for long durations, and then functional training, that was from sit to stand, that helped her in daily activities, step ups and step downs for her stair climbing in case if necessary. Then we go to phase 3, that is rehabilitation phase, where strengthening exercises are now increased. The number of holds and the number of repetitions of the exercises are increased. We'll include mini squats or the supported squats we can consider, wall slides, that is the supported squats, bridging exercises, functional training for gait training and stair climbing, sit to stand practices with increased repetitions, standing exercises, and for balance and proprioception, standing on one leg, dynamic balance training, stepping forward, backward, sideways, tandem walking, all of these exercises. And then the maintenance phase, where we'll make the patient understand her regular activities and progress strengthening exercises, endurance training for the muscles to get more strength, functional training to return to her household work, stair climbing, walking for endurance, and then joint protection and activity for activity modification. The ergonomic advices that we usually give, that is avoid prolonged standing or walking, performing prescribed strengthening exercises, use of cane or walker when needed, and take breaks frequently. That she must not walk for a very long period of time if the swelling reoccurs, probably. The rehabilitation protocols have been taken from these references. Thank you. Any questions?
Who's that?
I know a lot of times with our knee replacement patients, like a lot of time, like, so obviously, like when you're gonna have like a surgery like this is planned. It's not like an emergency surgery, so you're gonna schedule it and stuff. Did this patient do any like specific prehab before surgery?
Yes, we have seen pre-operative also I have seen her, and we advised her for the surgery, but she had her school and everything going on. She said, I'll retire and I'll get my surgery done. So that was her preference. And by that time, we taught her same strengthening exercises, and we taught her the ergonomics to sit down while she was working, to not stand for a prolonged period of time, use knee caps, knee socks, or whatever you know, whichever company they preferred, to use soft heels and sports shoes while walking. And whenever she used to do stair climbing, she used to always keep her right leg first and then the left leg. So we trained her pre-operatively also.
Okay, that's good. Yeah, that sounds very similar to what we do. And then I think the treatments were very similar. Did you find it really hard to get that extension fully back? Or was this like a case where everything kind of like came back naturally through exercise and stretching?
So initially, the extension was difficult, but later on, when her strengthening exercises and isometric exercises increases, her extension improved. And even while prone lying knee bending, also her extension and flexion improved.
So you did like a prone hang. Would you add a weight to that to help, or?
Yes, in the rehabilitation phase.
So further along in the rehab process, was it a goal of yours to try to be able to walk without an assistive device?
Yes, we wanted her to walk without any supportive devices, but initially she walked, but after a distance, she said, no, I am not able to walk. And then she used a stick, or probably she'll ask someone to give me her hand and I'll walk. Thank you. Any more questions?
Sorry, one more.
Yeah.
It said in there, partial weight bearing. Was that doctor's orders? Or was that based on her tolerance?
Based on her tolerance. Thank you.
I have
Thank
a
you,
I have
Harshmita. Next, okay, you also want to ask, she also want to ask something. Please come.
Sorry. Is she still experiencing pain?
No, she's not experiencing pain, but the stiffness sometimes comes because of the weather, but she takes care of it very well now.
Okay, perfect. Thank you.
Thank you.
So next will be Saurabh. He is going to talk regarding a patient who has undergone the ACL injury, and after that he has given the rehabilitation to that patient.
Good afternoon, everyone. I'm Saurabh Sharma and I'm from MPT Sports Medicine. And I'm here to present a case study on ACL reconstruction. This is the demographic data of my patient, and my patient name is Amit Kumar, and his age is 20 years, and he's an recreational football player. And the patient present with these complaints for 2 weeks. He was experiencing pain and difficulty in walking, and difficulty in bending knee while sitting, and difficulty in bending knee while lying on the bed or supine lying. This is the history of the patient. On 27 May 2024, the patient got injured, and he is experiencing pain and feeling instability in his knee. And then he taken to the nearby hospital for the further management, and but he got no relief. Then after 3 days, he went to the Fortis Hospital, Gurugram. Then MRI was done, then MRI findings showed grade 3 ACL tear, and the orthopedician advised the patient to brace the knee in full extension for 15 days before surgery, and advise to use the auxiliary crutch for walking. And on 14 June, he underwent ACL reconstruction surgery using semitendinous and graceless graft. Then after 3 weeks, he visited the physiotherapy department. These are the pain assessment of the patient. Intensity of the pain is 5 while bending the knee. Type of pain is dull aching. His aggravating factor is walking and sitting with knee bending and supine lying knee bending. And relieving factor is lying flat on the bed and cold application and pain medications. These are the observations. Build of the patient is mesomorph, and there is a fixed flexor deformity after 3 weeks. When he came to the physiotherapy department, the patient came with fixed flexor deformity, 10 degrees of extension lag was present, and attitude of the limb is in supine position is hip is externally rotated and knee is 10-degree flex, and ankle in the plantar flexion, foot is inverted. Gait is antalgic gait, and patient limp on the left side, and mid thigh and mid calf, there is the circumference of the mid thigh and mid calf is reduced. Then scar is 4 centimeter medial to tibia and 1 centimeter above patella laterally and 1 centimeter below patella laterally. External device use is knee brace and auxiliary crutches for walking. And palpation, there is no tenderness on the injured side, and slightly warmth. The knee is slightly warm because of swelling. And swelling, which is measured by me, is right side 40 centimeter and left side 30 unaffected side is 37 centimeter. The posture examination is, these are the findings. So iliac crust is right, iliac crust ASIS level, pelvic height on the right side because of limping, and there is 10-degree extension lag. And on the from lateral view, forward head is present and protruded shoulder and flexed knee, 10 degree. These are the examination, joint range of motion and muscle strength. Joint range of motion, active and passive range, and active and passive range of knee flexion is 10 to 16 degree because there is 10-degree extension lag. So 10 to 16 degree is active range and 10 to 64 is passive range. And knee flexion and extension, right side is 3+, others are normal. These are the circumference measurement of the mid thigh and calf. Mid thigh is 46 centimeter and left knee is 50 centimeter because of muscle atrophy, and calf is 37 centimeter and left is 40 centimeter. And limb length discrepancy is also present. True length is 83 centimeter on both the side, and apparent length is 95 centimeter, and left on the unaffected side is 97 centimeter. These are the gait assessment: left stride and left stride length, right and left stride length, left and right step length, cadence, weight of walking, width of walking base, and left foot angle, right foot angle. And these are the goals, short-term and long-term goals. Short-term goals are protect the graft, reduce swelling, restore patellar mobility, restore full extension, gradually improve flexion and patient education. And long-term is normalize gait and maintain full ROM, safely progress strengthening. And the pre-LEFS lower extremity functional scale scoring is 20, which means severe functional limitation. Then post-LEFS scoring was 38, which means moderate functional limitation. And phase 1 exercises for time period is 0 to 2 weeks. Icing 3 times a day, 5 to 7 minutes. Compression elevation, retrograde massage for swelling, to reduce the swelling, and ankle pumps, patellar mobilization, superior, inferior, and medial lateral glides, 30 glides each. Seated assisted knee flexion and heel slides, standing gastro stretch and soleus stretch, and VMO strengthening, calf raise, supine active hamstrings, quad set, straight leg raise, hip abduction, multi-angle isometrics, walking, and hold relax techniques to increase the range of the knee, scar mobilization. And these are the follow-ups. After 2 weeks, the flexion range was improved, which was previously was 60 degrees, 10 to 60 degree, and this was improved to 7 degree to 80 degree. Right extension leg is also reduced 7 degree, and quadricep strength was improved. Swelling also reduced to 38 centimeter, and post-exercise pain and swelling was present but reduced when patient elevated his leg on the stool while sitting. Advice to the patient is keep your knee straight and elevated while sitting or lying down. Do not rest or place towel roll under the knee to prevent extension lag, like fixed flexion deformity, and do not actively kick your knee out straight, or do not pivot on the surgical side. And these are the phase 2 protocols, 3 to 5 weeks. Continue above exercise, stationary bicycle for 10 minutes, and standing exercise, standing hamstring curls, step ups, and march, partial squat, exercise, ball squat. These all exercises are 12 reps each times, 2 times a day. Lumbo-pelvic strengthening also there, bridging, unilateral bridging, and clamshells. And proprioception training also, single leg standing with a slightly knee flex and static progress to dynamic unsteady surface, lateral step overs, lateral lunges, and front lunges. Then follow up is after 5 weeks, his range is also improved to flexion range is also improved 120 degree to 120 degree, and extension lag is only 3 degree left. Right knee extension lag is reduced and quadricep strength is improved. Swelling is not present, and his LEFS score is also improved 38, moderate limitation, functional limitation. But after when we after after this, I will hand over this patient to other physiotherapist because my clinical posting was over. So further follow up is not there, and follow up is not. Bas. These are the references. Bas.
Do you know what kind of repair that was used for the ACL reconstruction? What did they use to repair the ACL? Did they use a certain ligament or from another part of the body?
Yes, he's surgical history is they use semimembranosus and gracilis tendon for ACL repair. Yes.
And then, as far as how the person injured themselves, was it more of an internal rotation with a flexion injury?
As per the patient, the history was there was an impact with the player on his knee. After that, he's experiencing pain and instability in the knee.
Okay. And then one more. I saw that it said it was a grade 3 ACL repair or tear.
Yes.
What is that? What is that in terms of like the scale? I guess I don't understand what is the scale that how you decide it's a grade 3.
On the basis of MRI, on the basis of MRI, the MRI showed the findings that the grade 3 ACL ACL is injured. क्या बोलते हैं उसको? Okay. लेकिन उसमें तो लिखा ही होता.
So I think the tear in the MRI is being graded depending upon the amount of fiber disrupted. So grade 3 is tear about the
fiber disrupted. अच्छा ये गाना.
In terms of treatment, like I saw from 0 to 2 weeks, they were doing straight leg raises. I know sometimes in the acute care setting, like right after surgery, that can be really hard for patients. Like where in that 0 to 2 weeks were straight leg raises introduced?
We can advise them straight leg raises with brace on.
With brace on?
Brace on, yes.
Okay.
We can advise them.
And then did they have pain with that?
No, with brace on, the knee is already supported.
Okay. Would that be active assisted? Is someone
yes,
kinda...
we can first try active assisted. First, we can try actively. Then if the patient is not able to perform, then we can go for active assisted.
Okay, yes. Thank you.
So when you talked about the VMO strengthening exercises, is there a specific exercise that you found to be able to kind of isolate that muscle by itself?
There is no specific exercise. The muscles are working together. So we can't, they act in a group. So we can't isolate them, but we can strengthen them in क्या बोलूं यार? What, sir? No, sir. Group strengthening, yes. We can go for group strengthening.
And I know you didn't do the follow-up, but is there a certain like outcome measure that you look at for return to sport for the ACL?
No. I return to because I'm not there. I hand over the patient to other physiotherapist, so I don't know. Yes, sir. Thank you, guys.
Thank you, Saurabh. I would like to thank all the members present here from the Department of Physiotherapy, Amity Institute of Health Allied Sciences, Dr. Pradeep Ghosh from Maryville University, USA, and all the students who are present here to grace us for the day. Thank you so much for today's session. We would like to proceed for the lunch. I know you all are feeling hungry. Thank you.